Good morning, ladies and gentlemen. Welcome to the mHealth 2017 KKU. My name is Dr. Tikayu Johns from the Faculty of Dentistry, Khon Kaen University, and I will be your MC for the next 2 days. This is Thailand's first healthcare application bootcamp and hackathon. And we're privileged to have all the guest speakers from the United States and our bright young stars in the back there from wide varieties of schools, from faculty, I believe from Faculty of Medicine, Dentistry, Public Health, including business and other disciplines as well. This event is organized by Khon Kaen University in collaboration with MIT Sana, Massachusetts Institute of Technology. Before we start, I would like to introduce you to our newest video, introductory video of our campus. Everybody, please enjoy our newest video. to invite the It's a world event
เราต้องเปิดอันนี้ใช่ไหมคะสวัสดีค่ะอาจารย์ปุ้ม get so excited นะ just call me อาจารย์จิ๊บนะคะ สวัสดีค่ะ President of ขอนแก่น University Associate Professor Dr. กิติชัยไตรรัตนสิริชัย Honor Speakers and Friends Vice President Deans Students Honor Guests Ladies and Gentlemen On behalf of Khon Kaen University KKU eHealth Committee, I would like to thank the President for ฉันต้องทำยังไง พูดใกล้เกินไปใช่ไหมคะ I would like to thank the President for being the chairperson to open the KKU eHealth organized by Khon Kaen University in collaboration with MIT Sana today. KKU eHealth is an innovative program including boot camp and hackathon that brings together students and faculty from fields of medicine, public health, computer engineering, computer science, dentistry, social science, business design and related fields in KKU to collaborate on mHealth, which represent mobile and wireless communication technologies for health to ultimately discover novel solutions for healthcare challenges in Thailand. It is the collaborative project with MIT Sana, a group of Harvard, MIT, Massachusetts Institute of Technology, doctors and engineers who develop mobile health technology solutions. The project is under the theme entitled mHealth Thailand, Mobile Technology for Healthcare Improvement, which will be held at KKU during this week, the whole week, on January 9 to January 13. KKU mHealth Boot Camp, which is today, and Hackathon, which will be on Wednesday to Thursday, Hackathon promotes learning and bring together innovators as multidisciplinary teams to co-create digital solutions for health in Thailand. In this event, almost 200 interested people here with us today register to participate in KKU mHealth. This 5-day project is divided into 3 parts, including 2 days boot camp, today and tomorrow, at Sirikunakorn Building here at the President Building, and 2-day hackathon at the KKU Central Library, and a half-day presentation and award. This project received the great support from MIT Sana, thank you, Harvard Medical School and KKU staff, and the Center for Eye Research and Foundation and Education, CERE. Now you know how old I am. Fresenius, Kabi Thailand, through Cooperation Public Company Limited and the Faculty of Medicine, Khon Kaen University. Also, we have a great honor to have delegates from Massachusetts Institute of Technology, MIT, Harvard Medical School, HMS, the United States of America, and University of Waterloo, Canada, Colin, and also Thai Health Information Standards Development Center, Thai System Research Institution, Ministry of Public Health, Thailand, อาจารย์บุญชัยค่ะ ขอบพระคุณค่ะ to be speakers and mentors in this event. At this auspicious moment, it is my great pleasure to invite President Kitichai, Associate Professor Dr. Kitichai Triratana Sirichai, our President of Khon Kaen University, to deliver his opening statement for the KKU mHealth. Thank you very much, and please, President Kitichai.
Sawadee krab. Honored speakers,
KKU administration, as administrators, staff, students, distinguished guests, ladies and gentlemen. First of all, I would like to extend my very warm welcome to Khon Kaen University's green and smart campus. It is my honor and great pleasure to be here today as a chairperson on the opening sessions of Khon Kaen KKU eHealth. This is a vital and exciting collaborative event between Khon Kaen Universities and Massachusetts Institute, SANA, which will bring benefits to the people of health. We are in an era of transforming world. Digital technologies change the way we work, the way we live. These are challenges and opportunities for us to adapt and learn how to use these advanced insights and technologies to improve quality of life as well as health. Innovation of health science and technology make a meaningful and positive impact in global community. mHealth Bootcamp and Hackathon will provide not only the efficient new digital technologies, but also create multidisciplinary teams and working skills among KKU staffs, students, and international mentors. Research and develop. Center for Eye Research and Education CERE, Freshie News Krabi, Thailand, through Corporation Public Company Limited, and Faculty of Medicine, Khon Kaen University, for your kind support. May I now declare the opening of KKU eHealth Bootcamp and Hackathon Thailand 2017. I hope you all enjoy these significant events. Thank you very much.
Thank you very much, President of Khon Kaen University. I believe the next session will be a group photo, but please don't move. We will move around to get the best shot. Please be seated. The photographer and I will be upstairs and we'll be getting the best shot from up there, okay? Please stay where you are. ท่าปกติก่อนฮะ นักศึกษาที่นั่งบนเก้าอี้สีขาวถ้าสามารถยืนได้นะครับจะได้เห็นชัดๆถ้าเรียบร้อยก่อนครับ
Okay, this camera please 1, 2, 3.
And now strike a post. Now a happy post, a relaxing post. Relaxing and happy, smiling, whatever. Or like น้องนักศึกษายืนได้นะครับ นับเลยจ้ะ1 2 3 ยืนแล้วครับ Okay. Brilliant. Very lovely. Very beautiful picture. Thank you. Thank you, everybody. Now we'll be moving on to the first session of the first speaker today. Is Dr. Leo Anthony Celi. Dr. Leo Anthony Celi has practiced medicine in 3 continents, giving him broad perspectives in healthcare delivery. He holds a faculty position at Harvard Medical School as an intensive care specialist at the Beth Israel Deaconess Medical Center and is the clinical research director for the Laboratory of Computational Physiology at MIT. He also founded and co-directs SANA, a cross-disciplinary organization based at the Institute for Medical Engineering and Science at MIT, whose objective is to leverage information technology to improve health outcomes in low and middle income countries. He'll be talking to us today about solving the problems of healthcare. Everybody, please welcome Dr. Leo Anthony Celi. You can use my mic then.
Okay.
And you can be up there or down there. That's entirely up to you.
Hello. Thank you very much for having us. For most of us, it's actually our first time in Thailand, so we're really hoping that this will be the first of several visits to Khon Kaen University. Previously mentioned, I'm part of the Laboratory of Computational Physiology, and we have 3 research umbrellas as the foci of our work over at the Lab of Computational Physiology. The first one is MIT Critical Data, which is focused on health data analytics. The second one is SANA, which I will be talking more about in the next half an hour. And the last one is on PhysioNet. The flagship project of our group is actually a database called MIMIC. MIMIC stands for Medical Information Mart in Intensive Care. And it's a repository of data collected from intensive care unit patients who were admitted to Beth Israel Deaconess Medical Center, where I work. We have more than a decade of data, and in 2007, we did something radically different. What we did was we removed all the protected health information, and we made the database completely open to any investigators. So we have more than 3,000 investigators using our database. It is being employed in various phones because of the ubiquity of mobile phones. We have been offering a course on global health informatics. This spring, next month, is going to be the 7th iteration of the course. And during this semester's course, we are actually launching the MITx version of the course, which means that we are anticipating tens of thousands of students to take the course with us starting in February next month. We wrote a textbook to accompany the course, and it's a huge undertaking. And similar to our course, the textbook is going to be completely free. You can download the entire electronic version of the course starting in March. And we cannot teach about global health informatics without being involved with ongoing projects. And this is just a summary of the active SANA projects. They all entail the use of cell phones to improve the delivery of healthcare. Just a quick rundown. We have an ongoing project in India where we're using the cell phones to track the vaccination around the country. In Lebanon, it is being used to provide a personal health records for Syrian refugees in Lebanon. In Uganda and Brazil, we're using the cell phones to measure and track the surgical capacity of different hospitals around the country. In Haiti, we're using the cell phone to follow up on patients who just had surgery and providing a photo of the wound to inform the surgeons whether the wound is healing as expected. This is just a rundown of the previous studies. Some of them are now being implemented on a wide-scale basis. In India, the project involved identifying people who are high risk for cardiovascular disease. And as soon as they're identified, they're connected to the public health system. So you start more preventive measures to prevent complications from cardiovascular disease. And that the scale-up of that study has been completed. It was funded by the George Institute coming from Australia. In Mongolia, we partnered with Taipei Medical University in using the cell phone to triage kids who sustain burn injury so that the the provider at the point of care is able to make a decision of whether the kid has to be flown to the large hospital in the capital, or whether the kid could be taken care of in the villages. In Haiti, as I mentioned earlier, we're working with the community health workers so they could follow the patients who live in the mountains and who are not able to follow up with their surgeon after having undergone surgery. And these are just some of the publications that we have written to document all these projects. We have an ongoing funded project in Colombia. This is to develop a technology platform in order to be able to follow kids with convulsions. So in Colombia, we only have a handful of pediatric neurologists who are the experts in convulsive disorder in children. So what we're doing now is we're collecting EEG signals from those children who live all over Colombia and sending them to the pediatric neurologists who are found in Bogota. In Kenya, the project has been ongoing. We're using the cell phone to triage children presenting with diarrhea, with symptoms of the respiratory system, as well as rash. And I just came back from Argentina. We have several funded projects there using the cell phone to educate people with cardiovascular disease, to remind them to take their medications, to remind them about their appointments, as well as to make sure that they're taking their medications well. And finally, in South Africa, we completed a study in identifying people with high blood pressure, with hypertension, and it's using the cell phones also to facilitate the management of these patients. The last part of our initiatives with SANA is the most exciting, and this is having this mobile health hackathons as well as boot camps. So we have been around the world promoting the collaboration between software developers and the clinicians, so not just doctors, but nurses, community health workers, pharmacists. And together they come up with solutions to local problems. So we were in Popayan, Colombia. We're actually going to go back there in July. In Uganda, the project was focused on improving adolescent medicine and reproductive health. In Greece, we were there in 2015. And in Mexico City, a year ago, we created mobile apps to facilitate the care of elderly people who live in the cities. And last September, some of our colleagues from KKU actually attended an event in Taiwan, really leveraging cell phones to implement Internet of Things to improve healthcare. So my topic for today is solving the problems of healthcare. And it was difficult for me to look for a list of what are the problems that we face in healthcare. And as we travel around the world, what we found is that the problems of healthcare in the United States are similar to the problems of healthcare all over the world. And I found the original paper that established the AHRQ, which is an agency in the United States. It's an Agency for Healthcare Research and Quality. It was established in 1989 primarily to address issues that were raised by a report coming from the Institute of Medicine. And in that report, they cited, to me, are the biggest problems in healthcare: escalating healthcare costs, wide variations in medical practice patterns, and evidence that some health services are of little or no value. I'm going to add two more problems that I think are crucial in healthcare all over the world. The first is medical errors, or in the field of patient safety. And the last one is one of the dilemmas, or one of the biggest issues that we're facing now, which is the irreproducibility of biomedical research. So we'll start off with the rising healthcare costs. And this is a great paper talking about the costly paradox of healthcare technology. In other industries, technology usually makes that particular service cheaper with time. In healthcare, it's the opposite. As you introduce more technology into healthcare, it becomes more expensive. This is a good example. The picture on the left is a 5 megabyte hard drive back in 1956. And you could see the picture at the bottom is a small thumb drive that contains 1 gigabyte. And just to refresh people's memory, 1 gigabyte is 1,000 megabytes. The cost of a hard drive back in 1981, if you want to buy a 5 megabyte hard drive, it costs close to $3,000. This 1 gigabyte, or is it 128 gigabyte thumb drive, if you buy it in Amazon, it's $20. So you could see the impact of technology there. As we gain more expertise in that particular domain, it got cheaper. In healthcare, as I said earlier, things are getting way out of hand. These are some countries and showing you really the trajectory of healthcare costs. Thailand is not there, but I wouldn't be surprised. Actually, I anticipate that it's the same trajectory. Healthcare is becoming more and more expensive wherever we go. And somehow we have to address that issue. One of the reasons why healthcare is so expensive in the United States, and I presume that this is also the reason for why healthcare is expensive in other countries, is we waste so much money on unnecessary services. So the data coming from the United States, they're saying that for every dollar spent, in a huge chunk, the less treatments and tests a patient is actually a correct diagnosis of a disease that is never going to bother you in your lifetime. A very good example is thyroid cancer. In the United States, the number of thyroid cancers detected has tripled over the last 2 decades, and that's because we have the ability to do ultrasound. We find the smallest nodule, and if we find something, we take it out. They always say if you go to a barber, no matter how short your hair is, they're going to cut it, because that's what they do in life. And it's the same thing. If you go to a surgeon, they're going to perform surgery. In Korea, it is now the most common cancer. So they've seen a 15-fold increase in the detection of thyroid cancer. But despite, in the book by Gilbert Welch, he likened trying to catch cancer as trying to catch rabbits before they escape from the pen. But it turns out that not all cancers are like rabbits. Some cancers are like birds. By the time you see them, they've flown away. So that's true for very aggressive cancers. Even if you detect them early, by the time you detect them, chances are it's already spread all over the body. But there are tons of cancers that are like turtles. You don't have to catch them because the turtles are not going to leave the pen. A good example would be prostate cancer. A lot of thyroid cancer turns out would be like that as well. But we use up so many resources in trying to identify this type of cancers. So over-testing, we predict, is going to be more and more of a problem, and it applies to the increase in monitoring from all those wireless sensors and other new gadgets that is really being available now in the market. And we're identifying all sorts of omics biomarkers. And all these more sensitive technologies are going to be turning up more abnormalities that will not actually cause any problems in the future. And this creates a trail of data that we currently don't know how to interpret. The doctors will give a different diagnosis depending on which doctor you see. And this is due to the variability in doctor training, knowledge base, and experience. Another contributor to this problem is that there are so many uncertainties and information gaps, things that we still don't understand in medicine. And finally, we all know that we're all affected by our own biases. So doctor and patient biases are also a big contributor to this variation in care that we see around the world. I'm going to quote Arnold Relman. Arnold Relman was the former editor-in-chief of the New England Journal of Medicine, which is one of the highest impact medical journal. And when he was alive, he said that many people think that doctors make their recommendations from a basis of scientific certainty, that the facts are very clear, and there's only one way to diagnose or treat an illness. In reality, that's not always the case. I would actually say that's never the case. Many things are a matter of conjecture, tradition, convenience, and habit. This is Vinod Khosla. He's a venture capitalist in Silicon Valley. Over the last decade, he's been investing a lot of his money in healthcare. And during one of his interviews, he was asked by one of the reporters, what did you find most surprising about healthcare? And he said, there will be a consensus of what they recommend. And the research showed that it was 50-50. Half the heart specialists said this patient needs open heart surgery, and the other half said no, medications will improve the symptoms of this patient. So it's very, very unnerving or disturbing to know that whether or not they will recommend an open heart surgery on you depends on which doctor you see. And that was not the worst part of that research. They went back to the same cardiologist 2 years later. They gave them exactly the same case, and 40% of the heart specialists changed their minds. So it's not just which doctor. There could also be an issue of timing, good mood, and I think we should keep going with your medication. Evidence-based medicine. How well are we doing with evidence-based medicine in 2017? And the short, quick answer is not very well. In 2011, the Institute of Medicine convened experts to look at over 300 clinical practice guidelines. And clinical practice guidelines are what doctors and nurse practitioners follow in treating all sorts of diseases. And they looked at what's the evidence behind a lot of these recommendations. And these were the conclusion of that report coming from the Institute of Medicine in 2011. For many clinical domains, high-quality evidence is lacking or even non-existent. And often the guidelines are based on low-quality evidence or expert opinion. There are repercussions around the world. Guidelines coming from the United States, guidelines coming from Western Europe are typically adopted all over the world. So in countries where research is considered a luxury, all they do is they just copy and paste the guidelines coming from the US, the guidelines coming from Western Europe. But we have reason to believe that what works well for Americans or Europeans will not necessarily work well for the Thai people. And we really need to start performing more research in this country so that we would know what's the best treatment options, what's the best test options for the populations here. We've seen this medical pendulum where there's going back and forth of whether a treatment is good or not for a certain condition. I wrote here a couple of examples. One of them is estrogen replacement for women after menopause. When I was in training, we thought that every woman after menopause should be on estrogen because it helps prevent heart disease, but it turns out now that the new evidence is saying that that's not the case. Another good example is controlling the blood sugars of patients with type 2 diabetes. Before 2009, we thought that we have to control their blood sugars as strictly as possible. With the publication of the ACCORD trial in 2009, we learned that those who had the strictest blood sugars actually had a higher risk of death. So now we relax our guidelines a little bit. But we see this phenomenon of medical pendulum in healthcare. Another problem that I wanted to highlight is patient safety. One of the sentinel studies in the United States is a report, again coming from Institute of Medicine, called "To Err is Human." In that report, it estimated that up to 98,000 Americans die from medical errors during hospitalization. And this was based on 1984 data developed from reviews of medical records. More Than Medical Journal said that medical errors is the third leading cause of death in the United States. And these are just some of the medical errors that are causing preventable deaths. There's adverse drug events, hospital-acquired infections, diagnostic errors, surgical complications. So amputating the wrong leg, it was supposed to be the left leg, and they made a mistake. They amputated the right leg. Blood clots and the cubitus ulcers or pressure ulcers, as well as patients falling off their bed. So this is the British Medical Journal paper that got published just last year, citing that medical error is the third leading cause of death in the US. And in the United States, if you live there, expect that you will be harmed by a diagnostic error at some point during your lifetime. I had mine already, so I'm hoping that I wouldn't have any more medical errors in the future. I tried to look up Thailand. Are there studies looking at medical errors? And unfortunately, I couldn't find figures coming from Asia. So it's a field that is relatively understudied still. So no large-scale prevalence study to identify safety and quality problems in Southeast Asia. The last problem that I wanted to highlight is this problem of unreliable medical research. And to me, this is even a bigger problem than trying to cure AIDS or cancer. So unreliable medical research is the biggest healthcare problem that our generation needs to solve. One of the landmark study was published in Nature, I believe it was 2012, where some scientists coming from Amgen, what they did was they tried to replicate 53 of the most important cancer research. And they contacted the original scientists who performed those experiments. And out of 53, they got the same results in 6. So the other 47 experiments, no matter how they repeated the experiments, no matter how much they collaborated with the original scientists, they couldn't replicate the same results. And this is true across biomedical research. This is a more recent study looking at studies out of the field of psychology. They found that only 33% of those studies were replicable. And the others, again, they had some very good results. They got published, but it turned out that the results were not robust. And this is a fundamental issue because most of industry, as well as the way we practice medicine, is based on research. And if we cannot trust the research, then there's really something wrong with the system. We're not providing the best outcomes for the patients. This is one of the sentinel paper in this particular field. It came from John Unitas. It's from 2005. The title of the paper was Why Most Published Research Findings Are False. It's now the most downloaded paper in PLOS. And the experts have been citing some of the reasons why there's so much unreliability or irreproducibility in scientific research. One, there's so much emphasis on sensational discoveries rather than emphasizing reproducibility. We don't hear about experiments that yielded negative results. They are seldom published. And the most important reason for this unreliable research is an academic incentive system that pushes for publish or perish. So what are some of the solutions that we are advocating? Like it's one thing for me to enumerate the problems in healthcare. It's another to try to come up with potential solutions to all these problems. Technology is often heralded as one of the solutions, but the hope that an entrenched problem with social cost should have a technological solution is very seductive, so much so that disappointment with technology is inevitable. A lot of the diseases that we have now, diabetes, high blood pressure, they have what we call social determinants of health. And technology usually cannot play a large role in addressing social determinants of health. Like, again, we could give drugs for hypertension, for diabetes. If you're not addressing poverty, if you're not addressing all the issues that are contributing to complications from that disease, then you're not going to make any headway in terms of improving the health outcomes. A good example of the overuse of technology would be in malaria. The public health approach in terms of reducing malaria or any infections that are really spread by mosquito bites would be eliminating standing water, draining into swamps, providing mosquito nets, and increasing prosperity among those populations that are affected the most. But we hear TED Talks about recombinant vaccines, genetically modified mosquitoes, and mosquito zapping lasers. And they get to attract a lot of funding, even though we know that the simple things will actually reduce complications and death from malaria. So the ones on the right are sexy and headline grabbing, but suffer from the vanity of trying to impose a technological solution on what is a problem of poverty. So we've been going around the world in the last couple of years now, and our idea is we think that we have a better chance of addressing some of the issues in healthcare if we bring people together with various backgrounds. So what we're trying to do is let's team up clinicians, not just doctors, but nurses and pharmacists, and let's pair them up with engineers and data scientists, and together they get a fresh perspective on the issues that are plaguing healthcare. And we're also advocating the use of crowdsourcing. So the way we perform biomedical research now is that there is an exclusive cadre of people with PhDs and with expertise in the methodologies, and they're the only ones who are producing research. What we wanted to do is let's involve every single point of care clinician, because they may not have the engineering background, they may not have the methodologic background, but they have a lot of expertise in knowing what the problems are. They have a lot of expertise in understanding the context of these healthcare problems. So what we wanted to do is to crowdsource knowledge discovery and innovations in medicine, and we think that we can do this by bringing in people with different expertise. So we are approaching the problem vertically. We lower the barriers of participation to frontline clinicians, and we are also approaching the problem horizontally by extending an input role to non-traditional but interested contributors, including university students. Like, they may not see themselves as potentially contributing to the knowledge base in medicine, but with your backgrounds in machine learning, with your backgrounds in engineering, you could certainly provide solutions with impact. Patients could also participate in this knowledge generation, as well as entrepreneurs. So the term crowdsourcing goes way back into the 1990s. I believe it was first used by the editors of Wired before Jeff Howe and Mark Robinson. Simply defined, crowdsourcing represents the act of a company or institution taking a function to an undefined and generally large network of people in the form of an open call. The crucial prerequisite is the use of the open call format and the large network of potential laborers. As you probably know, the internet was developed using crowdsourcing with scientists coming from both the East and the West Coast, working together to develop what we now know as the internet. And we'd like to do that here in KKU. So last August, our colleagues from KKU actually came over to MIT and really jump-started the discussions to start planning for this event. And now we're all here, and we're going to be participating in this boot camp and hackathon, and we look forward to this event. Thank you. I think we have some time for questions, actually. I think...
We have like half an hour for question actually.
So I'm pretty sure that was a very provocative talk, and I will be very happy. I usually give a much shorter talk, so there will be more interaction between the audience as well as the panelists who are all here to be able to address your questions.
I believe there's a question back there, please.
Good morning, and thank you for your lecture. My name is Kanita, and I'm a PhD student from Center of Excellence in Community Health Informatics, Chiang Mai University. I'm just landed in Khon Kaen this morning, actually, to attend your public lecture. And I would say that this was very awesome to hear that there are so many people trying to working on them health to improve the health quality, especially in rural community. I would like to share that actually in our center in Chiang Mai University, we are currently working in mHealth too. Currently, we developed a mobile application that collecting health determinants data of the people around Chiang Mai, and also it seems like the fight this issue is kind of like far away from them. It's kind of like, it's maybe too high-tech for Thailand, something like that. But the fact that our application and also our data right now in Chiang Mai, we can tell you precisely how many people with NCD, non-communicable disease, how many houses in Chiang Mai without toilet in their own home, kind of like that. We have every health determinant data that we can show you if you like want to discuss with us later. And I am also here with my professor. He's the directors of the Center of Excellence. And also in our center, we have interdisciplinary researchers in the center, including computer science, engineering, doctors, pharmacies, and also nurses. And we have so many connections in Chiang Mai and also in Thailand. One thing that I want you to recommend us is how do you come up with the reasons to convince the policymakers or the governments to see that how important of health in Thailand community, so we can get more funding, we can get more resources, and we can get more people to working in our project. Thank you very much.
Thank you. I wanted to highlight what you really brought up with your comment, and that's the leveraging the value of data. So for the most part, in the past, we formulate health policy without the backup of good data. And I think what you're doing really is commendable, trying to collect the data so that you're able to inform the policies around healthcare. And we're hoping that we see more of these. So our background really is on health data analytics, and what we're hoping is when we come back here, we could actually have a data-thon where we start looking at the data that you collect from Thailand and start gleaning more knowledge. As regards convincing the government about the importance of mobile health and digital data, I think I'm going to pass that on to Dr. Boonchai.
Actually, I would like to have some comments or discuss with the MIT and Harvard too, because I think the missing part is that the information. You may come from the analytics, thinking that the data is already there. Why don't we do? But the missing part is how we gonna make the quality data, which is the field of the informatics. And the informatics, I think in the US, this missing part has been filled up by the Office of National Coordinator of Health IT. In the past 5 years, the Obamacare invests a lot on the health IT, which is not just the analytics or the technology, but filling gap that how we got to create the environment to have the good quality of data, which is lacking in many countries too. The report in 2000, the Earth is human. The Earth is human, which is leading to the introducing to the health IT development, and then with the Obamacare, the ARA, the Accountable Care Act, which is invest more than $30 billion on informatics, not the analytics, but informatics, how to get the quality data, which is very complex. Is this another world? How to link the genetic to the clinical care, genotype to the phenotype. This is a big one. We lack both in Thailand, not just the piece of, we have a technologist, the IT people who are very eager to use the technology, all the new data mining, artificial intelligence to produce some kind of the benefit, especially healthcare. In healthcare, there are a lot of startups want to build this from the technology perspective. And at the same time, the government, the administrator also just, why don't you use the data and help me to design something? They see these things like the technology. So if we have money, we choose buy it, and then everything will solve. So this is the challenge. We lack the continuum of what we call from the technology to the policy. And the big part, one of the big part is the biomedical informatics. You may be surprised that we have only less than handful biomedical informaticians in Thailand. A lot of computer science, a lot of technology, and also a lot of policy, financing, economics, but less people work on the information system. To recommend, I think the need is that you can see that we're talking about the universal healthcare coverage, which is, I will mention a lot, I will mention it in my talk in this afternoon. So I also struggling with you too. To convince that not just the technology part, but the missing part of the quality information, how we gonna have these qualities, is also the big one. What we should do, just keep on going, and then one day they will click the government like in the US. The US invests on AHRQ in 2002, and then they invest on the ONC, the Office of National Collaborating on Health IT. If you see in the statistic now, before 2011, only 11% of the hospital and clinic in the US adopt the electronic medical record or electronic health record. But with $3 billion investment, use the incentive from the insurance. Then right now it's 95% electronic medical record or electronic health record adoption in the US. We may need those. We already have the universal healthcare coverage, but we don't invest on the informatics. This is not answer, but more complaint.
Thank you very much for your clarification. Actually, I would like to say that I am actually a PhD student from biomedical engineering. I am a biomedical informatician, and my background is pharmacist, so I kind of like a hybrid type of human. And we are working in biomedical informatics for 4 or 5 years at our center. So with each other, this is why we are here, to find connections. Thank you very much.
Yes.
I think we do have time for one more question. Yes, please.
Hi. First of all, I would like to thank you so much for such a thought-provoking talk. My name is Atipong, and I'm from Faculty of Medicine, Khon Kaen University. I was very intrigued when you pointed out that a better approach would be to focus less on so-called novel technologies and focus more on the simple behaviors or simple actions that have already been proven to work. I wonder if that's the approach that you use as well when designing hackathons or choosing which approaches to or which solutions to focus on. Is that how you pick the projects, and how do you design the projects? Like, do you focus more on the simple solutions that have been proven to work, or is that the kind of thinking that you put into hackathons?
So the focus of our hackathons is for the technologists to have a very good understanding of the problem. Most of the time, the entrepreneurs and the technologists, they try to come up with solutions with a very superficial understanding of what's going on. And our idea here is really push forward design thinking. The only way for the technologists to understand the problems of healthcare is they actually start talking and working with the clinicians. And the solutions may be technologically savvy, it may be very simple, but I think a key step is for the technologies to have a very profound understanding of what the issues are. So it's not just a matter of, oh, let's collect the blood sugars of diabetics once a day. If you're not able to integrate that as part of a system-level approach to treating diabetes, then that's not really going to add any value. So what we're advocating is that the entrepreneurs and the technologists, they really need to, I think it's okay, they really need to have a better understanding of what the issues are. It's not enough to a lot of the startup companies would try to target low-hanging fruits, provide a very sexy solution for a low-hanging fruit without understanding the social determinants of health. So again, even if you're controlling the blood sugars, if that diabetic continues to smoke, then you're not going to change the outcome of that particular person. So to us, the real value is you cannot solve the problems of healthcare unless you truly understand that, and the only way to truly understand that is to be working hand in hand, really in very close contact with the people who are immersed at the front lines of care.
Thank you so much, Dr. Celi. Thank you very much for the thought-provoking and very stimulating talk. We're going to have now 10 minutes break, apparently. The break, it's just the room next door on my left. And please come back to this room at 10:30. Thank you very much. stand there. Okay. Yeah. It's entirely up to you. Okay. Would you like a break? Somebody will bring a break for you. Tea or coffee? Or anything? Tea.
Is that okay?
Okay.
Okay? Okay. Can you hear me? Testing 1, 2, 3. Too loud?
I think it's good.
It's good? Okay. Can you hear me okay? Is this loud enough? Too loud? Closer. You want it louder? There's going to be a little, yeah, there's a little feedback. Too much?
I think it's good.
Good? Okay. I can switch to the microphone if this doesn't work, that's fine.
I think if you need to walk, you can.
I'm not going to move. I like my safety, my protection. It's my.
So, welcome back to the second half of the morning session. The next talk by Dr. Kenneth Eugene Paik. Dr. Paik is a clinical informatician driving quality improvement and democratizing access through technology innovation, combining a multidisciplinary background in medicine, artificial intelligence, business management, and technology strategy. As a research scientist at the MIT Laboratory for Computational Physiology, he's investigating the secondary analysis of health data and building intelligent decision support systems. He's also the co-director of SANA, where he leads capacity building programs and research projects driving quality improvement through digital technologies in health. He'll be talking to us on design thinking in global health informatics. Please welcome Dr. Kenneth Paik.
Still good morning. Great. I'm glad everybody got some tea or coffee so that you can stay awake to my boring talk, but we'll see how things go. People are still trickling in. I wanted to get a sense of the room. How many are with a medical background? Dentistry, clinicians, nursing, public health? Okay, good. About less than a quarter, good. How about engineering backgrounds? Computer science, biomedical engineering, hard sciences, physics, okay. Humanities, social sciences, art, design. What did I not cover? I see some people haven't raised their hands yet. Education? What's in the humanities? Sure. Education? Education? Okay. No other volunteers. Okay, so my background in a former life, I was an engineer. I was a software engineer working in IT consulting primarily, and then I went to medical school, and then I went to business school, and even further schooling in informatics, medical informatics at Harvard. So I kind of at the intersection of medicine, technology, and business, and currently at MIT focusing on the secondary analysis of health data at the same lab as Leo, and global health informatics with this, and as well as digital health entrepreneurship. So my talk is on design thinking in healthcare. My outline for my talk, I'm going to set the stage a little bit, give a background on why healthcare is interesting, the various challenges and opportunities. Second, I'll touch on some common mistakes. Leo highlighted some. I'll reiterate some of those and touch on specifics within the development area. And third, I'll talk, the core of my talk is on the design thinking, the human-centered design for a solution and radical collaboration, and reiterate some final take-home messages. So to set the stage for a project, I'll just, at a very high level, talk about startups and the myth of startups. You know, you get a lot of news about unicorns and billion-dollar companies created out of thin air and then collapsing, a year later. And specifically within hackathon projects, I want to temper just a little bit, bring a little bit of realism into the excitement of this event. I think it's great. I think we're going to have great outcomes, and there's huge energy, and I love the audience excitement and generated from a hackathon and continue beyond. You're looking at a very small number, around 5% of projects continue on beyond a hackathon. And even going beyond that, if you're thinking about startups, technology startups, 92% of startups fail within 3 years. So, you're basically doing a shotgun approach and hoping that something hits, and sometimes it does, usually it doesn't. So just understand that when you're going into a project, and build that into your risk calculation for whether a venture is actually going to be worth it, or just understand that you are going to be facing a lot of hurdles and barriers on your journey through this enterprise. And what actually happens, particularly in the US and the Silicon Valley, is you hit a lot of pilotitis. A lot of startups get a lot of enthusiasm and a lot of hype, but with very limited return on investment. And these are things that you have to consider within the field in general. So the next major point is that healthcare is challenging. Maybe about 20% of you raised your hand saying that you're in the medical field, and you probably already understand that. But for the rest of you with an engineering background or education background, I really wanted to emphasize that it's very difficult. So does anybody know who this is? Okay, so Sherlock season 4 has just kicked off, and I just realized how much Colin looks like Sherlock. So it's pretty funny. Okay, so one thing I've heard a lot over the past 20 years is, we've had secure electronic banking since the 90s, even before probably the 70s. We're talking about between banks. Why don't we have a system like that in healthcare yet, right? That's probably very common. And, some of the implications are that business people are just better at knowing how to make things work, or doctors are just bad at business, or the government has that fault, We're all looking for Trump to fix things, but these are all completely wrong. I mean, maybe there's like a tinge of truth to that, but very little influence is actually driven by that. One of the core reasons is that medicine is complicated, right? The human body is complicated. There's so many different systems interacting, physiologies between genders, between races, and ethnographic backgrounds. And so, this is just a sampling. You can't even read it, and that's kind of purposely done because medicine is very complicated. There's so much science and medicine behind how the body works, how it gets sick, and how to actually cure these. Like Dr. Celi alluded to some of that, but this is just to emphasize it. It's not just a simple factor of connecting and balancing credits and debits from an accounting balance sheet, right? So, which is what electronic banking does. You're just simply moving numbers around and making sure it's transmitted securely. Within medicine, you have to capture and understand all this immense amount of data. On the left is just all the physiological processes, some of the physiological processes within the human body. On the right side, a very basic medical protocol for a treatment of a single disease. So it can be very complicated, and this is the type of information that we're dealing with and trying to strengthen, and oftentimes just narrowing on one small piece of this. So, because of the immense amount of information that we're dealing with within medicine, it's both a science and an art. We're trying to build an evidence base, but as Dr. Celi alluded to, oftentimes it's an art where we're just taking a gut feeling from our previous experience, trying to synthesize all the information we have and make a healthcare decision. Where we are now, on this previous, we've got this little tricorder, which in science fiction says, we analyze the body and we can know exactly what's going wrong. But with the type of information that we have now, we just don't have that type of granularity and specificity with any type of diagnostic tool that we have. Here's an example of some of the signals that we do have. So within an ICU, you've got all these physiological leads and monitors on a person. This is probably as invasive as we get these days within the hospital. But with any of these signals, you're balancing the invasiveness of the monitor. So how closely you want the sensor to be on your person versus accuracy, utility, and effectiveness. So something that's on the surface of your skin, you're not going to get a lot of, it's very easy to do, it's very not invasive, you're not going to be hurting the person. But the type of signals you're just going to get some electrical conductance on the skin, and the type of information that you're going to garner from it is just a bunch of fuzzy lines, and you're going to make a lot of guesses and interpretations, and maybe some gross estimates. But if you get more invasive, so like a catheter or like basically implantation, you're going to get a better signal, but then you're going to cause risk and detriment to the patient. So there's always going to be that trade-off with these type of signals and capturing these signals. So it's not just as simple as get as great information as you can, because if you do that, sometimes you can actually hurt the patient. So even with x-rays, you're exposing them to radiation and a health risk. And so what people get very commonly is actually increasing the risk of other conditions to that patient as you go along. So this is just talking about, you have the information, the type of training that a clinician has, when you have a student clinician versus a senior clinician attending, they have this base amount of schooling and data and information, but once you get to the higher, what you want is to be able to synthesize that information. And right now, computers, digital health can only help in the first, maybe second tier, but this is where Watson is supposed to be coming on, is synthesizing the knowledge and wisdom, but it's definitely not there yet either. So that's why getting this understanding of how clinical medicine works is going to be important in where you come in and intervene with your technical solution. In addition to medicine itself being complicated, the system, the overarching operations and legal framework and policy is very incredibly complicated. So this is the US healthcare system, and these are all the different players, stakeholders that impact it. Don't try and read it, but just know that there are so many different people and groups that have an impact in the US healthcare system. And so I'll get to some more of that. And more specifically, I wanted to touch on the global health challenges. So low and middle income countries, rural medicine, they face challenges that larger urban areas do not have to encounter. So the specific challenges include the rural nature of both the patients and the communities. So they have to travel large distances just to get some primary care. And then if they go into these areas, the coverage, the specialty coverage is much more sparse as well. So rather than, for instance, Boston having the highest density of clinicians in the world, you're going to have one clinician covering hundreds of miles, for example. And so the patients have to travel a great distance, and this exacerbates any type of condition that they might have. Second is the rural infrastructure. So just by being infrastructure, meaning the distance, but then also the poor roads that they have to travel actually, so it can take them weeks to travel just a couple miles rather than the couple minutes it might take in a highly developed urban area. That includes electricity, power, and other types of infrastructure limitations. The systems, the hospital systems and the clinical environment within these rural areas are also weaker, so that they have, rather than large academic hospitals and multiple cancer centers within this area, they have primary care clinics or community health centers to provide care with less resources, less human resources, the clinicians, as well as equipment resources. The low middle income country areas and rural areas also face a disproportionate disease burden. So in addition to all the common conditions that we have, they face specifically diseases of poverty resultant from the poor infrastructure. So they have poor water security, so they face hygiene and water purity issues, malnutrition because they lack access to foods, Infectious diseases usually fester people in the rural areas. There are much fewer rescue workers, and that's why the economic and health impact in those areas is so much greater when there's a natural disaster like a tsunami or an earthquake in those areas. In addition to this disproportionate diseases of poverty, they're also facing diseases of wealth, or the Western disease paradigm. So they're facing the same health conditions that wealthy countries face, partly because of increasing access to sugary foods, so poor diets, diabetes, cardiovascular disease, and such. So not only are they facing the diseases of pestilence, but also these things that we also face in the U.S. So there are growing disparities for these regions. So the poorest of the poor, the most vulnerable populations, they're unable to pay, and they don't have access to standards of care. On the bright side, the very, very lightly bright side, is that potentially yield the biggest impact for low-cost mobile technology and innovation. So this is where we're coming into play with the mobile technologies, the ubiquity of mobile health, ubiquity and portability of mobile health technologies. So, Leo highlighted the size and cost of a hard drive shrinking, but then on the other side, on the computing power side, if you think about the Cray power computers, so supercomputers, Cray power supercomputers from the 1980s. I don't know how many of you were alive then, but they were giant machines that filled the room, and they were the most expensive, millions of dollars, and maybe there's one in a university academic center. Now your smartphone has more processing power than that giant Cray computer. So with that understanding of the background and the challenges, there's a lot of opportunities for innovation within digital health and global health. So I started to talk about this, but the benefits of mobile health include democratizing access. We can overcome infrastructure limitations because of how portable these smartphones are. We've got some just sitting in our laps, but sitting in our pockets. With improving batteries, we're going to be able to do more things in these rural areas that have inconsistent power access. Improved diagnosis and tracking, we're able to use the computing power to improve decision support, disseminate protocols and guidelines, and really hopefully be data-driven, using this digital data to crowdsource data, and then also foster network effects for building the community and learnings. Don't read this. This is just saying that there's a lot of different applications within healthcare, mobile health, including education, data connectivity, clinical tools, decision support, et cetera, et cetera. My talk is not emphasizing any of these, but just to say that there are a lot of different applications within mobile health or digital health. But the bigger question is, why now? Why you? Why are you here in this room? Why are we here in this boot camp? And the three primary reasons I find are, number one, social justice. Healthcare, I feel, and many others feel, is a human right. Everybody deserves access to equitable and standard healthcare so that they can live to maximize their lives. And we have an opportunity within digital health, to actually improve lives. So you engineers who have a lot of options of, do I go into finance, make a lot of money? Do I go into a tech startup and start my, create a new WhatsApp or Facebook or whatever, Google? You have an impact, you have a chance here, while those are great tools and they have great impact to social justice and such, but here you can make a direct impact in improving lives with your skills, your discoveries, your innovations. Second, at least from an engineering perspective, we like a technical challenge. We like to solve something that hasn't been solved before and to push the limits of what we know and what we can do. So I think the cognitive complexity of healthcare is actually very attractive to some. So a lot of engineers like to solve these problems. They don't want to just keep reproducing the same broken wheel, but instead, let's try and solve these really difficult problems that others are too scared to actually face. So we have a chance to create and solve new solutions. And third, from the MBA perspective, there's a lot of business opportunities, right? So finance, stock trading, you're looking at innovating and trying to make money on milliseconds or fractions of a milliseconds to do trade sooner. But now, mobile health, global health is a new frontier where there's a lot of changing government regulations, so there's a lot of opportunities to make money. And then healthcare is seen as a human right, but then it's also something that people are willing to pay for. They want to live, they want to get better, they want to feel better, so there's a unique supply, demand, and willingness to pay balance here where people will pay to improve their lives. And so it's just a matter of figuring out how to take advantage of those opportunities. If you can't hear me, please raise your hand, or if I'm talking too quickly, I'm happy to change my speed as well. I have a tendency to mumble and talk really quickly, so you've probably noticed, so I take no offense if you raise your hand. So the second major point is to touch on some common mistakes, what we see repeatedly, right? We've got a lot of cool technologies that we love, we want to try. This presentation, this specific slide is actually a couple years old when Google Glass first came out, and you got the HoloLens, you got a lot of VR technologies. But how many of you actually have one, like an Oculus Rift? Not many. So, and are there actually practical applications? I know so much money went into Google Glass funding for clinicians last year, the year before that. Nothing's come out from them. It's very limited use, very limited utility. And you know, while technology is constantly advancing, you know, you've got the Moore's law reducing the number of transistors, or doubling the number of transistors on a processor, so technology is constantly booming. But the actual thoughtful applications of technology is sometimes lacking. Maybe we're not actually innovating in the right area, creating the right tools that are actually useful. Okay. So even within health IT, we've got a long history of implementation challenges that we've already identified. We know that technology is a problem, especially cost and reliability. We're just getting there now. In the old days, it used to be a Palm Pilot for those who are old enough to remember. And you know, now we're getting to Android 2.0 versus Android 6.0 is like light years ahead. So it's constantly evolving, but there's still challenges. The various systems, I'm just gonna, don't try and get all this down. I'm just highlighting that there's tons of challenges within implementing healthcare that we've already identified. Interoperability is very key, and regulation of policy has problems. And we've already identified there's already a large evidence base of unintended consequences. Why do these mobile health and digital health solutions continue to fail, even though we're putting so much money into this? A lot of it's focusing on the data, the workflow, communication, et cetera. So we know that there's a lot of problems. We know that there are common mistakes, but somehow we still continue to make these mistakes. And I just want to highlight 3 reasons why. Number 1, it's too often that we do technology first. You know, we had the question that was kind of obliquely related to this. You know, you've got a new technology, you start with this cool discovery, science discovery, and then now you want to find a solution to it, right? So you want to find a problem that applies to that solution. And this is too common. I mean, Leo kind of alluded to this. You know, there are success cases of this, right? So you've got the business case of 3M creating Post-it notes. You know, it was a non-sticky glue. They had no application for it, but then 5 years, 6 years down the line, it became a huge billion-dollar solution. But you can't go for that moonshot within healthcare all the time, right? You know, you're going to luck out sometime, somewhere down the line, somebody is going to do that. But if you're talking about probability, chances, and actually making a logical step to the innovation is you want to start with the problem first rather than starting with the solution. So don't try and take this technology that is this science technology and just try and shoehorn it into, in our case, rural health, because maybe it's not the best application. Instead, start with the problem, what the real problems are for in that particular environment, and then try and think of this universe of science and technology advances, which ones will actually improve that problem. Here is just a basic example. I like to do silly illustrations. So in the case of making music, you sometimes have a metronome, and it's a very useful tool. This thing's been around for, how many people know what this is, a metronome? Some people don't know it. Okay. How many people play music of any kind? Classical music, modern music, some guitar, violin, piano. So this is a metronome. It keeps very simple count. It's very accurate. It uses a pendulum system to basically count out how many beats per minute. You can range from like 60 to 120 to 212, something like that, beats per second. And musicians, or especially learning musicians, use this to be able to accurately keep pace for the music. So basically, it's a rhythm box to make sure that the music is on pace. And this thing's been around for hundreds of years, maybe. And this is what an engineer might design, while the thing on the left, the metronome is, maybe $20. The one on the right might be $300, and it uses digital equalizer and stuff. But it does, if you're just looking for keeping the same rhythm, the one on the right is just the costly alternative to the one on the left. And Leo actually highlighted a clinical example, which would have been better illustration in this case, of the malaria. So using a laser to zap a mosquito versus using a mosquito net. Mosquito net is $1. The laser is tens of thousands of dollars and actually not as effective. All right, so this is all around using technology, or going for technology first, trying to use technology, and then trying to shoehorn it into a problem versus starting with the problem first. So mistake number 2 is adding work. Coming from an engineering perspective or technologist perspective, I love being on the leading edge. I love picking up new technologies first, and it's worth the effort for me, like to get the newest app and try it out. And I know James has a Fitbit, and he was telling me about all the various cool things that he's been able to analyze and discover, and he's going to talk about that tomorrow. But we like it, but the majority of users don't have the time to take that on. So if you think about clinicians in particular, while the adoption of EHRs have a lot of benefit, we want to be able to do it because, if we think about the secondary analysis and the utility of that, both from a data science perspective, but then also a continuity of care perspective, there's a lot of benefits to implementing EHRs. However, the way that they're currently designed, they add long hours of work to those who are already overworked. You have clinicians in the hospital, 10, 12, 14-hour days, and you're adding 2 hours of paperwork at the end of that. They don't have a lot of time to actually adequately document within their EHRs. So many technology solutions, digital health solutions, add work. They ignore workflow implications, so they just think, okay, I want to capture this data, so who's actually going to capture that data? How is that going to be get into the system? And so many engineers have the fault of not getting the input from clinicians and making sure that you have clinician advocates on your team. And what happens is that clinicians or your users are going to find workarounds. So for clinicians, they're going to be capturing inadequate data. They're just going to be checking off boxes just to get the system done rather than actually leveraging and taking advantage of the powers of the EHR. So this example is they've got a Fitbit and basically using the metronome in the previous example to swing back and forth and say that you've done all this immense exercise while you're just sitting there watching it go. Mistake number 3, which Leo talked about earlier, is you neglect outcomes. You're not focusing on quality improvement. Some of this is just pilotitis, where you just want to start something just because it's cool, but then it stops working. It's not sustainable because it doesn't actually make an impact on clinical care and clinical outcomes. So always focus on improving lives, improving quality of care, rather than just focusing again on the technology or wouldn't this be great, or who might actually, or trying to sell it as the next generation of technology. Always focus on creating an innovation that impacts quality improvement. The next section is going to be talking about design thinking, so the key point. And, you know, this quote from Tim Brown, he's a little biased, but the point is that design in itself is too important to leave in the hands of designers. You want everybody to be involved in the design process. It's not just a matter of graphical aesthetics, handing it off to designer, giving them a design brief and getting it put back. It's how everything fits together, including usability and workflow. So it's not how things look, but then that's an aspect of it, but who uses it, how they use it, and how do they interact with the data. So another aspect is UI, user interface versus usability, or UX. Unfortunately, for those clinicians in the room, you've seen many forms and systems like this. You know, medicine is replete with bad UI and bad UX. Basically, traditionally, the traditional way of designing an EHR was simply replicating paper forms, which in itself were not that efficient, but they were optimized to capture data using a pen and paper. You know, usually doctors just cross and check off straight down the line and sign off on the paper. They only focus on maybe 10% of the page rather than the entire form. And so many EHRs are like this. And, you know, checking something off with a pen takes a fraction of a second, but if you're using a mouse, especially more senior clinicians who aren't familiar with a computer, can actually take 3 minutes to capture data or even longer. So this is not a usable interface for many clinicians. Within design thinking, the emphasis on user-centered design. I'm sure some of you have seen this illustration. You can probably Google it. It's very common and popular. Basically going through that there's a lot of miscommunication and misunderstanding of what people want. And what we want to do is actually get into the core of what the customer user actually needs. And that's why the design thinking process is crucial and important to implement, so that you quickly get to the bottom right rather than designing and deploying something that's unusable. So there's a standard design thinking process. There's many different types of processes. I'm not going to highlight this in explicit terms. There's a lot of design thinking courses that dive into it. But just really quickly, there's empathy, defining the problem, ideating, and trying to brainstorm solutions, building prototypes, and looping back to ideate and test and things like that. I'm going to highlight a couple of sections on this, but you know, the core point of design thinking is to bring the various groups together, and that so your solution sits in the center here, right? So that it's overlapping the business utility, business viability, the desirable of the product to the users, the feasibility of the technology. For us, we'd add a fourth circle of clinical impact. And through this process, hopefully you'll get in that center, because if you're not in any of those, the technical solution has a much more higher chance of failing. So the main points about the design strategy is these 4 points of radical collaboration, bringing together a lot of different backgrounds, which we're doing here at this hackathon and bootcamp, people with a lot of different backgrounds so that we can really troubleshoot the problem. And second is framing the problem, really understanding what the problem is rather than going from assumptions or your own perspective. You can get a lot of different perspectives to better understand what a viable solution would be I think I might touch on that later. Third is the brainstorming and general ideas. Too often we start with this design process with our own convergent assumptions and we replicate something that already exists. But with this design thinking process, you specifically want to facilitate divergent thinking, so you brainstorm as many ideas as possible and converge on the best solution. So we want to urge people to bring in as many different ideas. So if you're not an engineer, if you're not a clinician, we value your input because this will allow us to think more creatively about what the solutions are. And we want to be able to think laterally and brainstorm as many different solutions as possible so that we can hopefully test them and converge on a novel, innovative solution. In practical terms, things that you might consider applying during the hackathon or to your projects later is to, these are some, I think there are three, there might be four, I think there's three, specific things that you should specifically do for when testing your solution. Number one, stakeholder analysis. Understand who the various stakeholders are for your solution. Number two is workflow integration, making sure that it integrates closely with existing workflows and just doesn't disrupt it too much. And three is prototype validation. So stakeholder analysis is who will interface with the technical innovation. It's not just the end users, particularly in medicine, because the beneficiary of the healthcare, of the solution, who ultimately we hope will be the patient, is not usually the end user. So you have to think about who's actually going to be using the tool. There are some innovations that really focus on patients and having them capture their data or to educate them. Some tools interface at the care team, the clinician, nurse, or community health worker to facilitate their efforts. There's also organizational benefits. So hospitals will often deploy digital health solutions so that they can improve their efficiency or care coordination and things like that. So when you design your solution, make sure you think about as many different stakeholders as possible, specifically because within healthcare in the US and probably in many, many other environments as well, is that the users or the beneficiaries of the system is not always who's going to be paying for the system. So you've got government or insurance payers, while the beneficiaries are the clinicians or the patients. So also think about the deployment of your solution from the various systems. The previous, earlier in the talk, talked about the various, all the intersecting people, but also think about your deployment, while you want to think locally, like within the village or community, there's also larger organizations at higher up who might actually benefit. So while you might want to deploy something in a community health center, the regional government might actually be a larger stakeholder, more impactful stakeholder who might want to fund or support the organization operations. So by doing the stakeholder analysis, you can really focus on what will drive the adoption of the solution and identify what barriers there are. And as well as identifying who some key advocates will be. So a lot of times within a digital health solution, if you're an engineer, you want to bring on a clinician advocate, somebody who will really voice their perspective and then also communicate the benefits of your solution, be able to speak the same language to their decision makers. Workflow integration, this is the chart earlier about how complicated the systems are, but the whole point is that technology, as Leo emphasized, is only a discrete component of the whole intervention. You want to deploy the technology, but make sure that you're closing the care loop and focusing on quality improvement so that the technology doesn't disrupt the existing systems and workflow, but instead foster efficiency and usability and doesn't add work. Third is prototype validation. So rapid iteration of a possible solution so you can have proof of concepts and validate any early hypothesis as early as you can so you can adjust and pivot your solution. To answer the earlier question during Leo's talk about how to get public health, I think there's a couple points related to here. How to get the public policy people on board is two aspects. Number one is the stakeholder analysis, bringing on business people. It's a communication problem essentially, right? So you've got to be able to have somebody, communication and business development problem where we're always focused on the research side and making sure the science is strong as well, but you need to be able to communicate what your actual solution is. And then in addition to communication through business development is this rapid iteration. Get some evidence really quickly. Don't just go on the theory, just say, we think, give us $1 million to create the solution. Make sure you have some evidence, some rapid prototyping, proof of concept to say, we did this initial problem, we have this initial test, and we validated our hypothesis, so now we deserve the funding for this next round. So to reemphasize the design challenge, healthcare is complex, it's very challenging. We have to focus on clinical quality improvement, we have to integrate with various processes, and we have to foster workflow efficiency. So some take-home messages. We emphasize co-creation, teaming with partners on the ground who understand the local context. You can't just take what works in Boston and try and transplant it to Konkan. You have to make sure that you work with the local university, the local clinicians, who better understand the users and patients. So that you can so you can also understand what problems to solve, right? So what's actually big in Cambridge, Massachusetts is different from what we want to solve here. So same problem, different systems have a different implementation. Second is collaboration, working with various different backgrounds so that we really want to promote multidisciplinary teams, engineers, clinicians, policy, social work, education, design, to come together to build a holistic solution, to understand how to solve the problems with holistic solutions. So some various collaborators that you might consider. Clinicians obviously are important to understand the medical side. Public health is actually very important as well because you want to evaluate and monitor the solution. Too often we have clinicians who are only focusing on delivery of care, delivering as much care as possible for the patient, but the public health expert should draw them back a little bit and focus what's the most effective and utilitarian deployment for the resources that we have and which will make the biggest impact. So a clinician will, taking again from the health, I'll skip that. So third, I talked a little bit about the business aspect, but they're going to be important for the sustainability, the marketing, the communication of your solution. So while it doesn't have to be an MBA, but it has to be somebody or a researcher or an engineer who's facile in that area so that they can put together proposals and respond to RFPs to actually get the funding, to be able to communicate to the decision makers, communicate to the public policy makers or the foundations about the importance and impact of your solution, but then also develop new partnerships and relationships with governments, local, state, other NGOs to actually partner and use your solution. So it's actually important to bring it. And then social workers. Because so much of healthcare, especially rural medicine, primary care, rely heavily on systems rather than rather than clinicians, and the impact of any solution really ties up to follow-up and adherence. So, doctors see patients for such a limited time in the hospital, but then they go out to their families, and this is where actually the follow-up and adherence to treatment recommendations is actually more important than bolstering the primary care workforce. Second, we really another aspect we focus on is capacity building, making sure that we have locally derived innovation. It's great that we're here. We love coming here. It's been amazing to share and collaborate, but for the next generations to continue this, to continue the momentum and to really build on the capacity we have here, we have to have the innovations and changes come from you guys. To solve the upcoming problems, the next iteration of the next generation of innovations. So again, the caveats, hackathons are great, but with limited tempered expectations. It's great for learning, exploring, and iterating really quickly. And this is what we want to encourage you guys to explore and network with each other. And the objective, the long-term objective, is to succeed beyond this hackathon. We don't want to just focus on what your project is here, but build communities, network with each other so that you can actually learn from each other and continue to explore the next generation of innovations. So I'm going to close with just some characteristics of a successful team. Number one is collaborative. So you've got complementary skills. You've got an engineer. You've got medicine. You've got education, social workers, public health policies, people all together on the same team, working on a holistic solution because medicine is so complicated. It crosses so many systems, so many stakeholders. Second, it has good leadership. So it doesn't have to be a single person, but it has a group leadership, but you need good leaderships in order to identify when to pivot, when to change course, when to persevere, and actually when to give up, right? So you've got, within business, we've got something called the sunk cost fallacy, where we've already put billions of dollars into this system, so what's another $1 million to actually see it? Sometimes you just have to cut the cord and say, this is a waste of time. Experience is important, and this does not necessarily mean age, but experience in the particular area you're going to be targeting. So if you're going to be targeting a rural health solution, it doesn't necessarily mean to get the orthopedic surgeons on board, but rather the residents and the clinicians who are on the ground within the rural health area to provide the skills and insights to actually innovate a solution. Another aspect is empathy. You really have to listen and learn. Get the feedback in from your design groups, feedback from users, feedback from your data, and make sure you can adjust and adapt your solution. So to both your customers, but then also your teammates, understand, so if you're an engineer, hear what the clinician is saying about whether it's actually going to solve the problem. If you're a clinician, listen to the engineers about whether this technical solution is actually feasible, right? Okay. And finally, execution. Execution is actually probably the largest indicator of success of just getting things done. We have so many people with brilliant ideas, great ideas, but what it ultimately comes down to for the success of any startup and enterprise is actually just getting things done. Do things, fail fast, identify what actually works, pivot to improve it, and meet deadlines, deliver product, and solve problems. So for any draft proposal that you have, any research project, you have to get it done in order to publish and go to the next stage. So in closing, now it's your turn, to try and make a new innovation, make beautiful music, and et cetera. So our line is that geniuses are everywhere, and let's nurture them. So this is you guys. It's a bad picture, but this is what we got. All right.
Thank you so much, Dr. Paik. I believe we have only time for one question or comment. Okay. So we can move on to the last session of the morning. The next session is by Dr. Alon Dagan. Dr. Dagan is an emergency medicine physician with a background in biomedical engineering. He's interested in developing pragmatic and innovative tools for addressing the complex problems facing healthcare in the developing world. He's currently working clinically as an attending emergency medicine physician at BIDMC, St. Luke's, and Cambridge hospitals, and serves as instructor of emergency medicine at Harvard Medical School. In addition, Dr. Dagan is a research affiliate at the MIT Laboratory of Computational Physiology. He joined the SANA team in 2016 and has been assisting in the design and implementation of international hackathons, as well as providing clinical perspective to technical projects addressing healthcare issues. And he'll be talking to us on bridging the divide between IT developers and clinicians. Please welcome.
Thank you very much for the warm introduction, and thank you to everyone for the wonderful hospitality you have already shown us on our long journey here. So as I was wonderfully introduced, I am originally a biomedical engineer and then went on to study medicine and then did my residency in emergency medicine, which is where I spend most of my time working clinically. In addition, I work with Leo and Ken and the rest of the SANA team at MIT, where we are kind of working on exactly this, on bridging the divide between clinicians and IT, engineers, and sort of the whole technology and medicine divide. So I want to begin by saying Sawati Krap, maybe. And ooh, a round of applause. I was not expecting that. I appreciate, after seeing how long it took me to learn that one phrase, I appreciate all of your English. I'll try to speak as slowly as possible. And please let me know if anyone is having any difficulty following. So I'm going to start with this picture here. And I'm really not sure how many of you are familiar with what this is and how many use this. Yep, okay, we have a couple hands. So the real question is, how many people are still using one of these pagers? So, looking around the room, I think it's important to see that the three hands that I saw immediately go up were the doctors from Harvard, from kind of university hospitals, these large centers around the world. And the question is, we all sort of laughed when we saw this pager up on the board, but why is it that we are still using that in these major medical centers, at these kind of hubs of innovation around the world? Why is this still the device? And I think what I will argue is that the reason that this is still the device in these places is because we have this huge divide. We have this divide between the medical professionals who are incredibly busy, who are invested in care of their patients, and who have very little time for innovation and are very resistant to change. And then on the other side of the divide, we have all of this wonderful technology that's kind of looking for a home. And I would argue that in many of these big university centers, in these big hubs, this divide is even bigger, because people are structured in a way that they have their own areas of focus, they have their own sort of turf, their own territory, and they feel very protective of that. And so it's very difficult to bridge that divide and to bring people together. And I think just looking around the room and seeing how many different people there are from this large university who have come together is really a sign that some of these things that are a huge challenge in Massachusetts, at MIT and at Harvard, you guys are already demonstrating that you can do those things here. So I just want to sort of start with that. The real focus of this talk will be focused around a publication that was in the New England Journal of Medicine, which as Leo mentioned, is probably the highest impact medical journal in the world, or at least in the US. And it's talking about accelerating innovation in health IT. And what it describes is that the reason medicine is lagging behind so many other fields of research and so many other parts of our daily life is because of this divide. And I'm going to kind of go into that in a little bit more detail. Both Ken and Leo touched on this because this is sort of a focus of our work. But to kind of break it down a little bit more specifically, on the one hand, we have clinicians. And I'd say that the first thing that clinicians are feeling like they lack, that they don't have, is time. And part of that is because it's not built into the structure of what is expected from a physician. I think historically, there was this idea of the physician scientist. And going back to sort of the origins of medicine, you had doctors who were also researchers, who were also participating in the basic sciences. And I think as we've come along in the years and as history has progressed, we've lost a sense of that. I think part of that is because the thought is now that research is is a luxury, that research is something that only some very few people are able to do. And I would argue that particularly in this field of research, in information technology, that's not the case, and that the ability to do this research is much broader. You know, you don't need a very expensive electron microscope to be able to participate in these kinds of projects, and I think that doctors can be sort of slow to realize that this is accessible. I think the second thing that adds to that is that physicians, doctors, clinicians, nurses, pharmacists, we're not taught that this is something we can do. During medical school, I had no course where they talked about information technology. I can see that this is changing, and I'm certain that it's changing here as well. But for even the young generations of doctors and nurses, there was never any education about this huge aspect of health, and a really important aspect of health. And what this leads to is there's really no appreciation that they can contribute. Doctors and nurses, pharmacists, all of these clinical professionals don't realize that they have something to add. They're in this sort of bubble, in this world of working in the hospital and working in the clinic, and they don't realize that they speak a language that engineers don't. That just by living, just by spending those hours practicing medicine, that you are learning a language and a culture, and that language and culture is incredibly important for innovation. From this also comes the idea of low-hanging fruit, which means that clinicians don't understand how some problems might be easy to solve and some problems might be hard to solve because they don't have the technical background and they don't know which things are easy and which things are hard, and so it can be a very challenging place to start. On the other hand, we have kind of the IT professionals. So these are the engineers, the computer scientists, the data scientists, and they have all of this wonderful technology and they have all of these, potential solutions, but they don't necessarily have an understanding of the problems. And I think one thing that we really focus on, and one of the most important things to being successful, is to understand the problem. And so IT professionals lack this clinical experience. And the clinical experience is not something that can be learned in a textbook or looked up on Wikipedia. It's something that comes with an understanding of that language and that culture. A hospital is an incredibly complex system, and as Dr. Paik showed earlier, the healthcare system on a whole is incredibly complex, and it's not something that you can stop and take apart. You can't tell the hospital, we're going to take the day off and we're going to reorganize things. And so it can be very challenging to understand how that system works and how to influence that system. As an engineer, we would love to be able to stop, take it apart, understand how it works. And so it's definitely a shift in thinking to understand that this is not something that can be completely understood. That the human body is certainly not something that's completely understood, and all of the interactions between all of the people who are caring for these patients is something that has to be worked with and has to be worked within, but with the understanding that you will never capture all the competing influences. And I think that working with clinicians is sort of the way to enter that space. Practical feasibility fits in there as well. Knowledge of clinical utility. So what I mean by that is understanding when more technology is helpful, understanding when more information is helpful, and understanding when it doesn't contribute. It can be a very difficult concept that more is not always better, particularly in medicine. I think Leo made the excellent example of thyroid cancer, and that you see that the incidence of thyroid cancer in these countries, in Korea, has gone up 15 times. And the first thought is, oh my God, cancer is bad, there's more cancer, that must mean that there's something wrong, we have to do things, we have to do more surgeries, we have to give more medicines to try and bring this down. But it's a complicated system, and what that may mean is not that there is actually more cancer there, but that we're finding more cancer. and that the things that we're finding are not necessarily important, and that this more information that we've gotten, we found more cancers, that's leading to more testing, that's leading to more surgeries, and at the end of the day, that's not changing the thing we care about. It's not meaning less people are dying of cancer, because all of these people that we found these small abnormalities, they would have been fine either way. And so there's this very foreign concept on the IT engineering side, which is that more information does not always help people. And it really takes someone who is working in the hospital, working with patients, to be able to say, you know, in this case, more information is helpful, and in that case, more information is not. And so what I'm kind of coming at here is that it's incredibly important to pair these groups together. And right now, that's not always the case. So the most kind of common places, the classical areas where health developers are working, are in sort of three big areas, three big buckets. There's kind of the established IT companies. So these are the large companies, places like Philips or any of these large health information companies. And the challenge there is that they may work with some clinicians in some regard, but at least kind of classically, they don't necessarily see the benefit of working with these clinicians, and they're large businesses that are very protective over their technologies. And so they don't understand that often by sharing technologies, you can gain more benefit than by keeping them protected. Secondly, there's academics, so big universities, and this is something that is definitely a huge area of growth. But the challenge here is, as I said, different areas of the university don't necessarily talk to each other, don't necessarily want to talk to each other. They can be very defensive over their funding and over, well, if I'm doing a project with this other department, who is in charge? And it can be a huge barrier. And as I said, it's incredibly positive, and it's incredibly heartening to see how much you have been able to do even already in terms of getting everyone together in this room. And the third place is startups. And I think startups are exciting, but startups are often based on very focused problems or very focused technologies, even more so than the problems. And what we really need to be looking at is a big picture. What can we do, what small changes can we make in this system to allow more collaboration, as opposed to what technology can we try to fit into a medical problem. So I think kind of the big picture here is that long-term collaboration between physicians and between information technology professionals is really what is lacking and what's underutilized. So I'm going to talk about a few different things, but I think the point I'm trying to make is that when you don't form collaborations, you can end up with tools that are fundamentally missing what is useful, what is practical, and what is meaningful. And there's a term that Dr. Celi, I think, used as well, talking about paving the cow path. And Boston has notoriously windy roads that are difficult to navigate, and the legend behind that is that Boston's roads were originally the paths where the cows walked. And as the new technology came out to pave these roads, they just paved the cow paths. And the result is you end up with a city where it's not in a meaningful grid. The roads are sort of going anywhere that a cow might go. And so the danger with all of this is that we take a new technology and we apply it to a system that is broken, or a system that is poorly designed, or a system that does not take advantage of the power of this technology, and we end up with an electronic health record that is, as Dr. Paik was saying, is the same as the paper form, but now it's on the computer. And so you have all of the flaws of that paper form now on a computer, where it's less convenient. And you haven't harnessed any of the power of the computer, any of the benefits you could have gotten out of that technology, and instead you've put pavement on the cow path. So the big ways to address these issues are kind of the tenets, the goals of what we're doing at SANA, the goals of what we're doing here over the course of the week. And that's forming multidisciplinary teams. And when I talk about multidisciplinary teams, I'm talking about bringing people together from different areas. And I don't mean bringing them together for a day. I mean bringing them together in a long-term relationship. Because bringing an engineer and a doctor together at the beginning of a project is great. But as soon as they go their separate ways, the project will go separate ways. And every time they come together again, they'll realize that they're in different places. And so these teams need to be long-term. There needs to be a focus on the problem, on the user, on the end goal. And for almost all health projects, that end goal is to improve the lives of patients. And so we need to be thinking not about how many cancers can we find, but we need to be thinking about what can we do to extend and improve the lives of our patients. And as you change that scope, as you change that focus, you realize, okay, maybe the thing we should be measuring is not how many cancers we can find, but the thing we should be measuring is how can we make a difference in these patients' lives. So focusing on the end user. And as I was saying, to avoid sort of paving the cow path. So to think broadly, to not just take the system that we have in place and add technology to it. And the way to do this is to fail quickly. So the term for that is just to mean to cycle through ideas in a energetic way, but to be ready to say, okay, let's take this idea and let's try it. And if it doesn't work, let's figure out why it didn't work and let's try it again. And that's really the only way to adapt to the complex area of healthcare and the complex area of a hospital. Because if you just if you don't take that step of trying it, if you don't have a clinician or a doctor or a nurse who has access to the hospital, who can let you try these things out, then you end up with a large investment in something that doesn't have a practical role. So I'm going to be talking about the SANA approach. We've touched on some of this already, but I'm going to look at it from the perspective of bridging this divide. And then if we have a little bit of time, I'll also talk about sort of what another group is doing that's not us, but is affiliated with the hospital where I work. So there's sort of these three main areas of SANA. There's the open source technology, the education aspect, and the project incubator. And at its core, we'll be sort of learning a little bit more over the next few days, but SANA is a mobile health open source end-to-end application for Android. So what that means is we put a lot of importance in the idea of open source. We would like to be encouraging everyone to use this who finds it useful, and to develop an open source community where people can contribute to the program. This touches on what I was kind of saying, the dangers or the problems with a lot of large health technology firms is the idea that you have to protect your information, that you have to kind of keep it away from everyone else so that it's yours. And what we really feel is that by doing the opposite, by sharing as much as possible and by putting it out there and encouraging collaboration, that's how you get things to move forward. That's how you make something meaningful. So that's sort of the base of the SANA application. And the idea is to make a platform that can be used in a variety of ways. So Dr. Celi touched on a few of the applications, using it for telemedicine, whether it's a dermatologic issue in Mongolia or post-surgical issues in Haiti. The power of these cell phones is that they are everywhere. And it's something that is becoming more and more affordable, something that's becoming more and more accessible, and it's something that really can empower a lot of people and a lot of countries that otherwise wouldn't have access to this type of research, to these type of projects, all of a sudden are able to tap into this. The second kind of core focus is this education arm. And so in some senses, it's too late for some of us, for the system that's in place already. What I mean by that is a lot of these established systems, so the hospital infrastructure at MGH or at Beth Israel, at these large hospitals in Massachusetts where we're still using pagers, they're not set up to encourage collaboration. And so what we feel is that by focusing our efforts on educating the next generation of these clinicians, the next generation of these engineers, that we can try to make a change in that culture. And so education is what we're doing today, but this is not nearly as exciting as what we'll be doing the next 2 days. And a hackathon is a really wonderful way of bringing people together and generating excitement and forming these relationships and demonstrating in a real way everything that we've been talking about. So as opposed to me just coming up here and saying, you guys have a lot to learn from each other, instead we put you in a room, we give you a challenge, and we show you through actions that there's a tremendous amount that you can learn from each other, there's a tremendous amount that you can gain when working together. And to build off of this, we also have the Global Health Informatics course that is going to be offered that I'll talk a little bit more about, and the textbook that Leo touched on as well, because we really feel like this is our primary mission, to bring people together and to try and make a change in culture, so that moving forward there are a lot more young professionals who are interested in collaborating and who are interested in making real change. And part of that idea of moving things forward is the project incubator. So taking projects that come out of hackathons or projects that come out of problems from different areas, different parts of the world that can be helped or that can be solved with the use of mobile health and mHealth, and trying to support them as best we can, and trying to give people the tools to develop further and to support these projects as they move forward. This is the paper that kind of outlines this goal, the idea of doing global health hackathons in order to bring people together, in order to spur innovation. And this outlined the experiences that we had in several of the other hackathons over the past 2 years. And we have been trying to gain more knowledge from these events as we're having them, and so that we can kind of bring things forward and gain sort of more knowledge, more excitement for each event as we move forward. And there is a lot of excitement. I think that there's no question that hackathons are exciting, but as Dr. Paik was saying, it needs to have a little bit of, it needs to be more than just excitement. There's a tendency to get everyone together, to get really excited about it, to work on some great projects, and then everyone goes their separate ways, and that's sort of the end of it. And I think that even as we're getting this excitement, and even as we're moving forward and going into this project, it's really great to see how much emphasis all of the organizers have put into making sure that there's a future for these collaborations, making sure that this isn't, just one event, but that this is the start of something new. On our side, the way that we try to encourage that is through the Global Health Informatics course. This is a course that we offer at MIT, but also offer starting this February as a massive online open courseware through MIT, and we're excited to be offering that to anyone who is interested. And the goal here is to really take this concept of collaboration and take this space between medicine and engineering, and to try and formalize it in a way, to try and say that this is an area of itself, that global health informatics is a thing, and it's something that's worth doing, and it's something that's worth studying, it's worth forming a community around. And so we welcome everyone who is able to sign up for this starting in February. Similarly, we have the textbook that will be in conjunction with this course that is available for everyone to access. So I guess kind of before jumping into that, I would say the goal and the purpose of everything that we're doing here is to try and demonstrate that a lot can be done when people work together, and that technology alone is not enough to solve these problems, and that collaboration is key. And if it sounds like I'm being repetitive on this point, it's because that is the purpose. And I think that moving forward, I'm really excited by what I see here. I'm incredibly excited about the next few days. And I think what we can do is we can open up to questions in the last few minutes, or I can move forward and talk about some things that the other groups are doing. But I know lunch is coming, and I'm not going to be the one to stand between you and your lunch.
Any question? Comments? นักศึกษาถามผมแปลให้ก็ได้ฮะไมโครโฟนมา
For you, I have seen your presentation about the democratizing access. What does this mean?
What democratizing access means?
Yes.
Basically, democratize means make available to anyone. So, across the world, no matter where you live, if you have enough money, you can get the best healthcare. You can get, if a wealthy person gets sick in US, Thailand, Dubai, even Uganda, if you have enough money, you can get quality of care. But when we're talking about democratizing access, is we want to give standard levels of care to everybody, regardless of how much money they have, regardless of where they live. So that's what we think that technology can provide or help provide or begin to provide. It's not going to be the same level, but hopefully will bring everybody to minimum standards. Even if you're making $50,000 or if you're making $1 a day, hopefully you're not going to be dying to preventable causes of disease. That's what we want to happen.
For the second questions, for both speakers, for my question is, are there any platform that can help in resources country and as well as the developing and any kind of healthcare sector can have the collaborations that not just only insurance reimbursement? Which kind of platform, or are there any developing platform?
It's a complicated question, and the bottom line is it depends, from my perspective, it depends on the local environment. So we'd have to take a closer look at your institution, your local environment, and hopefully bring in people that are experienced worldwide or locally with mobile health. So talk to Boonchai, talk to us, and really take a close analysis to what workflow and systems are in place already. And hopefully there will be some tools that can be rapidly deployed to make an impact, or let's say identify some problems where we can hopefully design and build a solution that will be useful for your local system. I don't think there's any, right now, as you can tell from our slides and from worldwide, there is no iPhone or Android deployment that is universally applicable in any environment. It has to be customized for the unique problems and infrastructure and workflows for your system. That said, there are tools that you can hopefully adapt. So open source tools, open source or closed systems that you can use as part of your solution for this innovation.
Any questions by the students? Can I ask a quick question? Are there any differences in health IT utilization between society with universal healthcare and prevention and society without those?
So I would say that in a lot of ways, you guys are miles ahead of the United States health system in the ability to bring together huge amounts of information. So I work at Beth Israel Medical Center, which is in the heart of Boston, and there are two large hospitals that are across the street. You can look out the window and you can see Dana-Farber, you can see Brigham and Women's right there. And if I need information on patients from those hospitals, I have no direct way of getting it. I have to request medical records, or I have to call someone on the phone and who has access and ask them to get it for me. And it's because these institutions have been around so long and they've been kind of entrenched. They've been sort of stuck in their ways. And the ability for a country that is kind of skipping that in some ways and developing this system new is wonderful. You guys are able to often have access to this information and collect data in a much broader way than what we have in the US. I think it's almost a parallel to some countries. So in the United States, when we first had the internet, we had dial-up, and then we had the invention of cable modems, we had landlines, and then we had cell phones. And when you go to some of these lower and middle income countries, they just skip that first step and they move on, and no one has a landline, no one has a telephone with a wire, because everyone just gets cell phones. And it can be similar in the health field, where countries that don't necessarily have that history, don't necessarily have that tradition of these hospitals that have very strong personalities and strong roots, are able to sort of skip some steps and design something that can often be more effective.
Absolutely. So that's one of the points that I flew through in my presentation, is the barriers to adoption. So large existing systems, they have, or large hospital systems have existing systems in place, so you have to build and innovate on top of that. If you're a greenfield, if you have nothing there, you can actually adopt the latest technology. So in the old hospitals, you have to build everything based off of Windows PC, Windows 2000 probably, but here you can use Android, iOS, because there's nothing in place already. So that's certainly a pro. Another pro is in certain environments, you're able to bring together the stakeholders and decision makers a lot. You can recruit advocates and proponents to the system a lot easier. So in systems like Boston, and in fact some of our other partners, it's been challenging to bring the engineers and clinicians together, the differing. So in one of our previous hackathons, we had a hackathon with the engineering university, but to actually convince the medical university, they had some early discussions, but in the end, they dropped out because they couldn't come to an agreement because of heading. So here, it's been great and amazing to see the collaboration across the schools and departments here at KKU. You've got your medicine, dental school, you've got the engineering school, all of them coming together to make this a dynamic event, bring together all the collaborators. So that's another amazing thing that you have, you're able to do really quickly. On the downside is, of course, I forgot what I was going to say actually. So there are absolutely downsides, but I can't think of them at the moment. I was just too excited about this event.
Thank you so much. Yes, microphone, please.
When Dr. Paik talked about the stakeholders, I believe that there are people who are comfortable with technologies and not comfortable with technologies. And even though we work together, come up with really good solution, but I think the biggest problem is how to make them trust on our solution. So can you share on that?
Yes, and actually that jogs what I was thinking about, the differences between different environments, different countries. While the technologies might be the same, the user experience and the skill of the various users can be very drastically different based on your deployment. So that's another reason why you can't just take a technology that's used in a hospital to another country, another region. For example, our Haiti project, while we have resident physicians like Alon's age and younger who are actually using the system, they're very familiar with smartphones, it's actually deployed for community health workers. So these are people in the rural communities who normally don't use cell phones. They're actually day laborers. They work in the fields. And one of our researchers shook hands with a day laborer and he said it's as hard as rock, right? So you can't actually he can't press the buttons. It doesn't register on the smartphone. And these are the systems and usability that you have to consider when you're actually deploying to the local environment. That's why it's important to think about the various stakeholders and users. So can you repeat your specific questions so I get back on target?
I think my specific question is that the problem is how can we make the people who's not comfortable with technology trust on our solution? Building solution, extremely good solution, but when people don't want to use it, then that's the big difficult question.
Absolutely. When you're talking about barriers to adoption for technology, how do you get that? I alluded to bringing on advocates, so clinician advocates, user advocates, bring them into the design process. So if you're an engineer, bring a clinician onto the team who's actually going to use it and provide you feedback. And in addition to making sure that your interface and your user experience is useful to them, they can also start communicating and speaking their own language so that they can actually be an advocate to other clinicians, to communicate that to the adoption and encourage people to start using their system. And I alluded to, actually, sometimes that's why it's useful to bring on humanities people and business people, because they can help package that into a useful communications package, marketing piece to really recruit users, which is an important aspect of any executing any deployment plan. You have to do that marketing to the user. You have to go through the training systems all in place, which oftentimes engineers or clinicians aren't adept at. So you have to make sure you have that full, robust, multidisciplinary team.
And I would just echo what Ken said and just kind of add that I think part of the challenge is if you're taking a system that you developed and you're bringing it to a clinician and you're saying, I have this great solution for you, that is a much more challenging task than to work with the clinician from the beginning. And then you kind of get an insider, which is exactly what Ken was saying. But you get someone who can instead of you going to the clinician and say, look at this thing that I made, instead now you have a clinician who says, look at this thing that we made together. And that you can imagine that that's a much easier way to get something kind of used in practice.
Time for one last question before we go to lunch. I can smell food now in that room. Okay. If not, thank you very much, Dr. Dagan and Dr. Paik. So you could have for 50 minutes lunch break, and lunch just the same next door, the same room as break. So enjoy your lunch and come back at 1 o'clock. Yes. No, the lecture first. Thank you so much.
interoperability ให้ผมพูดภาษาไทยหรือภาษาอังกฤษผมว่าพูดภาษาไทยอาจจะดีกว่า
ถ้าอันไหนเป็นคีย์แต่ละพวกภาษาอังกฤษเผื่อวิทยากรถ้าเด็ก
พาเนลในภาษา
แต่ในห้อง
อันนี้ภาษาอังกฤษอยู่แล้วแต่ไอ้ตรงนี้เนี่ยผมอยากให้ดูว่าถ้าเกิดมีคนไทยเยอะหรือคนต่างชาติผมพูดภาษาอังกฤษเนี่ยผมว่าจะยิ่งสื่อสารยากผมไม่มีปัญหาเรื่องพูดหรอกครับ
ตรงนี้ก็ได้นะคะอาจารย์ออกไปข้างหลังออกซ้ายมือนี่เลย
Hello again, everybody. Welcome back to the afternoon session of the eHealth 2017. This afternoon, we'll begin with the session by Dr. Bunchai Krisanayotin. Dr. Bunchai Krisanayotin earned his medical degree from Chulalongkorn University and board-certified internal medicine and preventive medicine from Thai Medical Council. He spent 15 years working at rural public hospital as an internal medicine clinician. While he was working as a clinician in the hospital, he was also responsible for the hospital information system and oversaw the hospital. In 2008, he received his MS and PhD in health informatics from the University of Minnesota in the United States. Currently, he is the health informatician and research manager at Thai Health Information Standards Development Center, an affiliated agency of the Health Systems Research Institute, Ministry of Public Health, Thailand. He'll be sharing with us on the topic of Asia eHealth Information Network. Ladies and gentlemen, please welcome Dr. Bunchai.
It's an honor and privilege to have an opportunity to come here and talk to our colleagues from Boston and also our friends from Khon. Thank you for this network called the Asian eHealth Information Network, which I will talk more about this network. This network is more interested in health IT in Asia Pacific. We know we have a lot of friends in Asia and happen to know Leo through friends from Philippines, and then I got involved in be providing some kind of the presentation in the global health informatics run by MIT Sana. That's why the relationship come, and so with the two-side relationship, I have an opportunity to come here. My topic this afternoon is more on maybe bigger or in the global side, global level. So, has anyone know about the SDG? SDG. So I said I can talk about topic about this my network, which is now working with several developing partners like the World Health Organization and Asia Development Bank and other UNICEF and other developing partners to try to develop the National Health Information System or the eHealth in Asia Pacific. So this is the background that I have the opportunity to come here, and as I say, it's honor and be very privileged to come and talk with you. So anyone know about the Millennium Goal, the UN Millennium Goal, and this is the sequel or the following of the Millennium Goal. So what is the SDG, the Sustainable Development Goal? Is the agreement of the countries around the world under the UN assembly that we will take the look at the target in 2013, what the country or the goal want to be achieved. And then they have a negotiation between many countries, many organizations, and then come out with 7 universal goals. And with these 7 universal goals has 169 targets. And with a lot of at least 230 indicators to measure how the how countries and the world want to move on. And this is what we call SDG. And right now you can see that every country will, when we're talking internationally, will look at the indicators or the goal that how many goals that each country can achieve. So it's very comprehensive. It's talking about involve both people, prosperities, peace, partnership, and planet. So it's talking about green environment, talking about the climate change, and also talking about the equalities, the wars. So they say that SDGs are integrated and indivisible, which means that it integrates together all 17 goals. Global in nature and universal applicable, and unprecedented in scope and significant, which means that they create a very ambitious goal that we, as the global citizen, what would we like to see the world in 2013? That's the SDG. And you can see that they have 17 goals. And all among these 17 goals, we have health. Health is one of the 17 goals. And among these, there is 13 targets under this. At least 26 indicators. And what is significant is that how we measure the development for each country towards this goal. To have ability to measure or to benchmark each country, we need information. And how they need information to every aspect, like you can see 5P. And you can see that health, to have the ensure healthy life and promote well-being of all at all age. Mean that you can see that when we're talking about the care, we're talking about the determinant of health too. And with these 7 sustainable or SDG, the linkage between the goal, the third goal, the goal of promote healthy life and well-being at all age. You can see that we can look at four categories. First is the risk factor about health, which this is all the factors that related to health risk. The determinant of health, the environment, the education, the gender equality, the equity issue like war or the accessible, the democratic accessibility for health is also under this kind of the categories. And the last one is how to collaborate to every stakeholder to achieve these 17 sustainable development goals. So boil down these kind of the big global goal into the action or problems in health. We can see that there is a lot of challenge or problems related in healthcare that related to achieve this goal. You may, we are familiar with this, right? Universal healthcare. WHO said that universal healthcare coverage, universal health coverage is the very effective to promote to every country to implement this universal healthcare. Also address address specific health target like the HCH is a reproductive, maternal, neonatal, child and child health, HIV, TB, malaria, and this is neglected tropical disease. This is all the problem that all the countries are facing. NCD, non-communicable disease, the environmental health risk, the pollution, and the health system strengthening. The action, another action is the leaving no one behind. Right now, one of the problems, I mean, in many developing countries and also in the both global is the identify people. Some countries they don't even cannot identify people. There is invisible people. They may be risk to the human trafficking and another problem. So this is the action. If you look from the goal, the sustainable development goal, this is the action that related to health. This is the sample of the biggest, of the one that we call the universal health coverage. We are familiar right now in Thailand, we are fighting between Ministry of Health and the National Health Security Office. The US are now very anxious about Obamacare to be abandoned by the President Trump. And also a lot of issues that related universal health coverage. So this also need information. And this to measure this kind of the progress and also how we gonna strengthening or have to make this happen needs all the information. This is the sample that they are looking for some kind of the sample of the indicators. Look to monitor and evaluate the progress of the in each country toward the sustainable development goal. I forgot one slide. I think many, if here are more engineers are not familiar with what we call the health system. Health system composed of the six major components they call the 6 building blocks. First is the healthcare delivery system. The second is the workforce. The third is the financing. Fourth is the medicine, technology, drug. Fifth is the leadership and governance. And the sixth one is information. These are the building blocks of health system, which mean that with these 6 building blocks, we have to strengthening all this. Then we can achieve healthy life. With these 6 components, one is the information system. WHO know that to strengthening health system, it need to strengthening health information system. And before, I think before 2011, the ICT group, IT group or ICT group, are you familiar with ITU? International Telecommunication Union. It's similar to the WHO. The WHO is in health side. The ITU is in telecommunication side. They both sides see the potential of ICT or technology to strengthening or to make the social better and also the health of the people better. So before 2011, both of them are trying to create the guideline or recommendation for countries to develop the electronic health system or the health information system that can be to support the health and healthcare. But they like Ken said, they are, and Alon said that they have different perspective, and also they also lack of the perspective of each other. So in 2011, they come together. WHO and ITU, they come together and issue we call the eHealth strategy, and WHO, ITU, National eHealth Strategy Toolkit, recommend country how to develop good health information system using the information technology. WHO also urge, WHO also have a resolution. The WHO know the potential of the health IT or health information to strengthening health or strengthening health system. And they have one resolution in 2005 that encourage every country to develop health IT infrastructure or e-health infrastructure, collaboration between public-private sector. And in 2013, they emphasize this with another resolution that every country have to draw roadmap to implement, to use the ICT or e-health and doing for health data standard to develop policy legislation mechanism to link another overall national e-health strategy to create the national health information system or the information system that can be strengthening our healthcare and also prevention. So this is the kind of the guideline for a country to develop the health information system. This is the 7 components that need to develop the information system in the country. You can see that right now, many organizations, they have their own health information system. They are silo. They cannot talk to each other. And sometimes, several times, there is no structure, no system that to build or to help country to develop this. And this is the 7 building blocks of the e-health or the health IT on the national health information system. Good health information system need leadership and governance. Do Thailand or other country have the leadership and governance? In the US, I think the leadership and governance for the health IT to develop health information system in the US is the ONC, the Office of National Collaborating for Health IT, which is the leader or the look at the overall how the information system in the country should be linkaged or developed. Strategy and the investment, the legislation, policy, and compliance and workforce. Many countries still working on the privacy and confidentiality of the health information system. Thailand don't like the US. The US have HIPAA, and our friend from Boston see that it's a much barrier, right, to exchange information. But this is a concern about the privacy and confidentiality. And you may not realize that HIPAA is one of the models for many countries to look at the HIPAA law, how to protect health information of people. It is too, stringent and to constrain a lot of data sharing, but it's also protect. So it had several models. The European have some model of protect health information system for individuals. Thailand, we still don't have this. We still talking about how we're gonna issue the law to protect individual health information. The law is still in the parliament to consider. Not to say about the health information system. You know, in Thailand, if you go some province, we still arguing how we got to share the information, how much the information can be shared. Workforce in Thailand, we don't even have the position for the health IT people in hospital. We only have clerk or get the, technician from the, from Pantip to working, to working at the IT technician in hospital. No position for them. This is the big barrier that we don't talking about all these components. So this is the 7 components that have to be working on to help build the eHealth or the National Health Information System. And this is the detail of the issue that have to work on in these 7 components. Unfortunately, in Thailand, even leadership and governance, we don't have the national governance body that have a vision to develop health information system of the countries. And this is another big challenge or big barrier. AeHIN or Asian eHealth Information Network, we do the study. We look at working using the framework of the WHO ITU eHealth strategy toolkit to see how well each country progress or working on these 7 components. And we do the kind of the survey with 21 countries, which is the member of our network. And this is the country that respond to our survey. You cannot read it, but look at the colors. Just look at the color. And the color green is mean that countries are now starting to aware about working on these 7 components. And then the red one is that no action along these 7 components. It looks like that in Asia Pacific, countries are more alert that they want to use the health IT or eHealth to strengthening health system and healthcare system. Thailand is over here. Over here. We are much better than many countries. Compared to Myanmar, Cambodia, Vietnam, we are much better. But we still lacking. We still lacking behind Singapore, Brunei, or the Hong Kong. And this is just summarize the result. So what we found is that 12 of the 21 countries has been taking steps implementing their national eHealth strategy to all aspects of the 7 eHealth components, which means that they're starting to aware that they have to work on this kind of all the 7 components, not just the technology, or they have to work on the legislation to workforce. 9 of 21 countries need to be planned, implement more eHealth related agenda. And this is the, let's say, are more lag behind among 21 countries that respond to the survey. With this survey, we found that information system in each country are not interoperable. They are silo. Even they are aware, but they still have a silo system. Information system don't talk. They cannot exchange information. Even they don't exist. The information is not exist. So every country face the same. Medical school, the medical hospital, each department is still siloing. The system is still silo. This happens across the country. Every hospital similar to this. We want the information system to be able to exchange and working as an integrated system. another issue that we found that many countries get money from donor, and they don't feel like the owner of their health information system. They said many poor countries, donor like UNAIDS, ASCAP, when they get foundation, when they implement malaria system, they also put the malaria information system. Where implement TB system, they call the TB information system, and all these silo system burden people who work in healthcare. They don't talk, and it's the same. Some country don't quite aware that this is their own. They own their health information system. They think the country don't perceive that is the national information or health information system is their own job. So one thing that in our network encourage is that this is our country, so we own our health information system. And the third one is that we found that when we are not good in every aspect. So if we come together and we work together among countries in Asia Pacific, like Philippines might be good in governance, Thailand are working more on the data standard and interoperability. Another country working more on the civil registration system. And we come and work and share together, then we can go together and develop the national health information system. So this is the principle or the philosophy of people we call the health IT professional, who in the Ministry of Health and also in the academic in Asia Pacific country, mostly from ASEAN country, come together forming the informal network, which we call the Asian eHealth Information Network. And we work together in these 4 areas. The first area is that to build capacity of the people in each country to be able to develop eHealth civil registration system. And another area is that we sharing information peer-to-peer, helping each other. We promote or working on the standard and interoperability in the country and across the countries. The third one is that enhance to try to have the higher level to advocate for the leadership and sustainable governance of the health information system. And this is under, because we come together, the developing partner like WHO, ADB, UNICEF, World Bank, they saw the value that if we work together to developing this, we can work going very well. So they provide the technical support, give some money, and this is the kind of the roadmap or the step that we think could, if we build capacity around this area, it could be help countries to be more build health information system effectively. We have a general meeting. This year will be the 5th general meeting, the annual. The first one is in Bangkok in 2012. The last one in Bali in 2015. And we are going to have the next one in March in Naypyidaw, Myanmar. So this is some kind of the short story about this network. It's starting in 2011. A group of people from the Ministry of Health, they have a workshop in Hoi An. And they found the same the same challenge and the same problem that the information is silo. They don't have the good information system. Healthcare are not supported by the health information system. So they do the interoperability workshop. And then luckily 6 months later or 3 months later, they have a big gathering of the people in Ministry of Health and academia in Asia Pacific, in Manila, supporting in here, doing the Asia Pacific HIS Leadership Forum. From this, people like my friend from the Philippines and also friends from Laos and come together. We have the same challenge. We have the same question. Why don't we forming the network? So at the end of 2011, we got some kind of the small amount of money from the WHO to write up the forming, how we can form the network that can work together. And we successfully that we can have our first AeHIN general meeting in Bangkok in 2012. After that, a lot of activity come. The developing country, developing partner support this. And we look at the agenda that all the country have to do to achieve the Millennium Goal and to achieve the SDG. So in 2013, we have a second general meeting in the area of IT for universal healthcare coverage. During the year, got money from funding from the developing partner to do the capacity building. We training the health IT from Ministry of Health about the enterprise architectures. Doing the training about the COVID. COVID is the framework for the governance, the COVID. The COVID. We do kind of a lot meeting to building capacity and also exchange information about how we can share knowledge. And in 2013, we do the general meeting. Topic is the USC with ICT, and this is all the activity along the 2 or 3 years, 2014 to 2016, and we're gonna have this next in March in 2000 in Naypyidaw. It is the digital health conference focused on sustainable, how to achieve sustainable development goal. You can look at the schedule of the conference over here. Unfortunately, this is the invited only conference. It's not academic. It is not academic conference. It's more on working to develop health information system. But we also had a lot of activity around this conference to say that it is the invited only, which means that it is not. It doesn't mean that you are not invited. If you are interested, you can contact us, and then we can invite it. But we call this invited only because the funding to the developing country participants are from all the developing partners. So there is no registration fee. The conference is like NGO. The NGO work is not the commercial work or the academic work. So it is not focused on research, academic, but focus on implementation, how to work, how to make it real in real world. Right now, I think I would encourage all of you to go to the website, and you can be one of the members. With one of member, you will get the news message, and you can be, if have opportunity come, you also can apply for the scholarship. If we can get from the, from the developing partner for a project, then we can distribute to all with the selection of the group. So right now we have around almost 1,000 member, individual member, and which is the country, 55 countries. And this is all the, up to June, we have this kind of the group of people who interested to working. Like I say, this is the peer-to-peer. This is not who will dominate another. It kind of the network. And this is all the developing partner that working with this network. I show this because of this is the architecture that we think that our network use as the kind of the framework to developing integrated health information system or eHealth, not just the silo. So I think I made the time and have more 20 minutes to talk, to answer questions and comments. So in short, I'm talking about, introduce you about one of the UN SDG, which is, I think, maybe news from your perspective. But to have the good health, you need the information system, the good information system. And good information system need to be built, need to be developed, and need the collaboration. And not just the technology. We need 7 components of the 7 components of all. We're talking about adoption. Adoption is one of the big issue in getting the health IT or technology to the people. And the adoption is not the IT issue, it's social issue. We have the topic of socio-technical aspect of health IT or eHealth, which is totally working with workflow, organization, people, not just the IT. That is one sample. That 7, why the 7 component, it have to be developed across the board. So I will end up my talk. It might be very, very far from the our workshop, boot camp, or the hackathon. Any comment? Questions?
Thank you, Bunchai. Very interesting talk. So definitely the MDGs and SDGs are important and are at the high global NGO levels. What I find is that they're high level conceptual goals that you set forth for an organization or country. But what's the connection between these high-level goals to actually impacting? How do you get to those high-level goals to impacting care at the individual level, at the local communities, to the local patients?
I think our workshop and our conference here this week is more clinical informatics. I'm talking more a very bird eye view, very high level view. Millennium Development Goal, as you see, that is kind of the goal that we said in 2015. Every country want to achieve this. So those are more looking at the developing country. US, UK, Europe, they don't even care about this goal. But the low middle income country looking at these kind of the develop to achieve this goal with the support of several WHO or UN or other organization. It's the goal that they working toward to. So after 2015, they call the post 2015. So they develop another goal they call SDG. This is a very good question that how we can connect a very high level to the healthcare. We're talking about the quality of data as I discussed this morning. Actually, data to monitor those need to be from the point of service. People at healthcare, at the point of service, have to be benefit from the information that they collect. They not just collect data to serve this kind of the goal. And those goals have to be, very close to the individual, to the individual system, individual people. Actually, the health information system at the point of service or at the operational side is the kind of the fundamental part that can be serve both the way how we develop healthcare and also feed the information to the high level. But you can see that countries, world organization, or even the developing partner or the foundation like Gates, Rockefeller, they look, they want outcome, they want data, and this is I think in the last 2 or 3 decades they found that if they implement project, they implement information system, then all they are silo. This silo information system doesn't serve the people who work at the point of service. You can see that in health center, they will have to put on the information to malaria, TB, HIV, or every system. And these are all not integrated. And the challenge is that they are not have a structured, good health information system. eHealth or health IT, we believe from Leo this morning that it will be save cost, help lower medical error, and then improve qualities. This is all the benefit that we can see from the ICT in healthcare, and it's through the information system. Actually, it's not very precise to answer your question that how we link the point of service system to this goal. But you know, this is the mandate that each country, developing country, are look up to. Country like Myanmar, Laos, Vietnam, when they got supporting money, every organization, how is your working through this development goal? I think people who in public health are more familiar with this kind of the concept.
I was wondering how your Asian eHealth Information Network is going to incorporate mHealth or mobile health technology into its standards.
This is a very good question. Actually, this network, actually, everyone can be part of this network. Because it's starting with individual. Looking at me, I'm the one that works for the information system in hospital and in the country. I'm also suffering to all of the problem here. But when we come as the network, we know that we can learn from each other. And we can help from each other. as an individual or individual who work in clinical information system, who work in public health information system, we face with all the technology, how we gonna use mHealth, the mobile health, to improve the quality, the efficiency of the people at the point of service. How we gonna do the architecture or the blueprints of the information system that can serve both people in point of service, and also we have to report to the manager, to the government. But we are the doctor, we are the people who work in health center. And we, along the way, we know that the information system is very complex. Healthcare system is complex. To do good healthcare, you need a good flow of information. Information not just only help the administrator to decide or the policymaker to decide the resource, but also need by the clinician at the point of service to decide which test we should order, which drug we should order. But right now, information system in many countries are designed to serve the reporting system, mostly in lower income country or middle income country, even Thailand. Thailand is around 20 years behind the US. We are now arguing, talking about how we pay. The National Health Security Office, SPSC, are now arguing with Ministry of Health or hospital, กระทรวงสาธารณสุข They said they lose, the hospital cannot survive. We still working on this kind of the money thing, the billing, which is the US and UK and Scandinavia. Their information system about the billing has been established for 20 years. They are now working on clinical information to build more quality of care, minimal the medical error. So your question is about technology to work with to work with this kind of the development goal. They look the technology as the tools, but the tool need to have the structure of the information that can be integrated. It comes to my comments that there is three parts, right? The technology, the informatics, and also the healthcare. They speak different language, and all need need the information to do their work, and also developing their kind of the way to work on. And all these complex things, how we gonna work together to create the information system that serve both people who work at the point of service and also every stakeholder, the researcher, and also the administrators. Okay.
I'm not sure if this information might help you on your work or your policy, and also it might answer your question as well. The project that we are working on in Chiang Mai University, we used mHealth technology to collect all the determinants of health of people in Chiang Mai. Basically, we knock on every door of each house in Chiang Mai and collect all of the health information of people in Chiang Mai, all people with good health or with bad health, with bedridden, with disability. We have all the information that could answer the MDG, actually. And we are also working with the community hospital we're trying to develop the network infrastructure to retrieve the electronic health record from the hospital and integrate it into our mobile health system. And then the health practitioners who are working on home healthcare service, they can just pinpoint every house with bedridden patients or with disability. And they can just visit them with iPad or iPhone and then retrieve the health record from the hospital individually for this patient. And it is like fast, it is precise, and it is save time, and it is also paperless for the community, for the healthcare team, and it is actually awesome. And actually, some people from the Ministry of Health used to visit us in Chiang Mai. I'm not sure if maybe you would like to visit and maybe trying to help each other to like improve this system to like implement in all over the country, because I'm not sure if there is another same system or same application in another province, but in Chiang Mai we're doing very well, and right now we are expanding to the 25 districts all over Chiang Mai and also some other province. Maybe we should talk and discuss more on this system that I think is really, really work. Maybe it's not, it's hard to say that we couldn't get enough funding from the ministry. Right now, most of the fundings are from private sector, yes, and from SSS, Thai Health Promotion Foundation, yes, and some from Sawathoy and STDA that help us doing this job. And if actually some people from above, from the Ministry of Health, see that our projects is impact to Thailand, maybe we could help to improving this system together. Thank you.
Thank you. Thank you for this, fascinating information. But, you know, I at the perspective from the central or have deal with a lot of group, this kind of local success project is all across this country. There is several provinces or even several regions have similar, this collect data from say the healthcare information from hospital and also from the determinant of health from the communities. But the challenge is that they cannot talk to each other. So we working, what you explain is here. It's more on service and application. This is the biggest challenge of the information to integrate all. If you look at the hospital, right now we don't have the healthcare information that can be transferred, exchanged from one hospital to another hospital. Only the hospital in that province use the same application. Right now in Thailand, the hospital application that are very popular, they call the HOS XP, allow 70% of the market share of 800 community hospital. But these application cannot use in Songkhanakarin Hospital, cannot use in the Sirirat or Chulalongkorn University. It not designed to work with the big complex workflow, and this is the biggest challenge for the referral information system, that referral data we call the health information exchange. Yeah, the point I would like to point out to you that you extract host XP because they use the same application, but the application in health object in Songkhla Nakarin, they use the different standard. So the language is not the same. You better attend my workshop. Later, I will talking about the interoperability and health information standard. Then you can see the complexity of the information, not the technology. The information, how it is very difficult to integrate the information system. And Chiang Mai is very famous for, I think Chiang Mai University, Suan Dok University, one got the award from the UN award on integrated health information system.
Yes. Yeah.
Thank you. That is my plan. This is I plea for the minister or the prime minister also that we don't have even have the national national governance for health information system. We don't have the national health IT governance system. So please appoint me to be the minister. Then I will push on this, but it is not possible.
Right.
It is not possible for to one people to do that.
Right. Thank you so much for the talk. Thank you, and very stimulating discussion as well. So we are going to have the 1 hour and 15 minutes for the workshop session. There'll be some changes in the workshop schedule. As you can see from your schedule here, there will be 3 workshops. Workshop number 1 is quite popular. There are now 60 people enrolled in this workshop. So we're going to change the room. The workshop number 1 is the Introduction to UI and UX Design by Mr. Colin Fair. The room will be changed from room 4 to this room. You'll be remain in this room, workshop 1, because that room doesn't fit 60 people in that room. So the one who's going to join the workshop 1, please remain in this room. And workshop 2 and workshop 3 will be in the same room. Workshop 2 is about interoperability and health information standards by Dr. Bunchai. You can continue discussion there. And the workshop 3 is image processing by Dr. Nawapak Anand. We'll be in Karapuk room 6. So please enjoy the workshop, about 1 hour and 15 minutes. Thank you very much.
เป็นพยาบาลผู้เชี่ยวชาญแล้วก็เป็นกรรมการสภามหาลัยด้วยแต่มาฟังอาจารย์เพิ่งทราบเลยที่เพิ่งได้มาที่จริงน่าจะควรตัดเท้านะ